So hopefully,
Oh, I'm in now.
this guy just blew the already.
Morning, everyone.
Good morning, everyone. I will wait a few more minutes to see if we can get more members of the working group to join. All right, well, it's 9:03. We do have enough for a quorum I can see on the screen, but for the sake of just ensuring we do this correctly, I will go ahead and do roll call. So Terry Kearns,
Present.
Mark McBride, Scott Killebrew,
Good morning, everyone.
Senator Rochelle Wynn, Lieutenant Diane Goldstein,
Present.
Assemblyman Max Carter,
Present.
Assemblywoman Danielle Gallant, Jonathan Dalton,
Present.
Dr. Mujeeb Shad,
Present.
Burton Tabak,
Here.
Dustin Hines,
Present.
Catherine Cotter,
Present.
Joshua Garber,
Present.
John Oseguera,
Here.
and Marla McDade Williams. I am here. So good morning, everybody. Thank you for joining us on this Friday. As you know, we do try to limit the meetings to 3 hours. We have a relatively full agenda today. But first, I would like to open with public comment. To provide public comment telephonically, dial 1-775-321-6111. When prompted to provide the conference ID, enter 950-345-302#. If providing public comment during the Teams meeting, unmute your microphone prior to speaking. Persons making comment will be asked to begin by stating their name for the record and to spell their last name. Is there anybody wanting to give public comment this morning before we start? Okay, not hearing anything, then we will go on to agenda item 4. So the minutes for April 12th were sent out yesterday afternoon. If you had an opportunity to review them and want to move on them today, that's great. If not, I'm perfectly fine waiting for approval until our next meeting. The minutes for June 25th are in draft. I haven't had an opportunity to review those, so I didn't post those for review at this time. So anyone comments about the minutes from April 12th?
This is Terry Kearns for the record. I did review them and I moved to approve those minutes.
I second it.
And second, I'm sorry, was from,
I said I second it.
I'm sorry, who was it? I can't see on the screen.
I second it. Can you hear me?
Okay,
That's
Dr.
it.
Shad, I just, please identify yourself
I'm sorry.
when you speak,
Yeah, this
just
is-
because I can't see everybody on the screen. And
Oh, okay, I'm sorry.
talking.
Okay. This,
Okay,
this
thank
is
you.
Dr. Shad. I second the motion.
Great. Is there any further discussion? Okay, all in favor, please say aye.
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 Any
Aye.
Any opposed, please say nay. Okay, the minutes are adopted. Now we will move on to agenda item 5. It's a presentation regarding the program administered by Oregon Psilocybin Services, the Oregon Health Authority, Angela Albee, manager of the program. Angela, the floor is yours.
Thank
I'm
you
in.
so much.
Are you?
Thank you so much, everyone. It's really great to be here. Thank you for the invitation. I'm going to provide a general overview today and then open it up for any questions that you might have. So first off, my name is Angie Albee. I use she, her pronouns, and I'm the section manager for the Oregon Psilocybin Services section. My role is to lead and support the implementation of the Oregon Psilocybin Services Act, while also serving as ex officio executive director of the Oregon Psilocybin Advisory Board. As you know, Oregon is the first in the nation to implement a regulatory framework for the provision of psilocybin and psilocybin services. And for reference, the Oregon Psilocybin Services Act is codified in Oregon law, and you can find that in Oregon Revised Statutes, Chapter 475A. And as most of you also know, psilocybin is still a Schedule I substance under the Federal Controlled Substances Act. So a brief overview of our section. Our section is housed within the Oregon Health Authority Public Health Division Center for Health Protection. We are organized into 3 program areas. So our policy and engagement program, our licensing program, and our compliance program. And our mission is to create safe, effective, and equitable psilocybin services in Oregon, while also centering justice, equity, diversity, and inclusion within the statutory container of ORS 475A. Also, as part of a state agency structure, we support the Oregon Health Authority strategic plan goal to eliminate health inequities, our state health improvement plan, Healthier Together Oregon, and also public health modernization goals for our division. So Oregon Psilocybin Services is focused on a public health policy approach that holds promise for healing and wellness. This is not a medical model or clinical model, although we are working on a continuum of care to bridge opportunities for dual licensed providers, which I'll talk about in a little bit. We understand that many people belong to intersecting communities that experience discrimination and disadvantage, and specifically when working within systems and institutions. And so as part of our state agency structure, it is our priority to reduce harm to communities and make accessibility a standard of practice rather than an exception. And so we are deeply committed to creating accessible, inclusive spaces within our statutory authorities for folks to participate and share feedback and recommendations and engage with us, and also committed to setting a very strong precedent for public health and safety for the nation as we move forward. So I'm going to talk a little bit about the model and kind of walk through some of the licenses. So under the Oregon model, again, this is not a medical or clinical model or a dispensary model. Clients may access services for any reason, and they do not have to be a state resident. And while no prescription or referral is required by a provider or a physician, clients who are over the age of 21 years of age may only access psilocybin at a licensed service center after completing a preparation session with a licensed facilitator. And these preparation sessions we'll talk about in a little bit. There are 4 license types, which are renewed annually. First is our facilitator license. This is for individuals who support clients through psilocybin services. And those 3 components include preparation sessions, administration sessions, and integration sessions. The Oregon Psilocybin Services Act requires a non-directive approach to psilocybin services, and that means that facilitators will be present with clients to support them without projecting or directing the client experience. And this really is important for the preparation session and creating a client-centered approach to addressing whatever they're walking into the door, with their intention to address. Prior to applying for a license, facilitators must complete an OHA-approved psilocybin facilitator training program, and this includes core training, it includes practicum, consultation, a comprehensive skills exam, and a regulations exam. Facilitators are prohibited in Oregon from handling, selling, administering, or otherwise touching psilocybin products or consuming psilocybin products with clients. A service center license is for the premises where psilocybin services may take place, and specifically the administration session has to take place. And again, this is the session where clients consume psilocybin and stay at the licensed premises. Some may offer large spaces for group administration sessions. Some may be smaller boutiques or urban spaces that specialize in individual sessions, and others may be more retreat models out on a larger property that offer outdoor administration sessions as well. And licensed service centers are responsible for the sale of psilocybin products to clients for administration sessions. And finally, next is our manufacturer license. This is for the licensed premises where the indoor cultivation or processing of psilocybin products will take place. Now, there are over 200 species of psilocybin producing fungi that grow naturally around the world. And at the recommendation of the Oregon Psilocybin Advisory Board and the Products and Research Subcommittee, only Psilocybe cubensis can be used. We adopted that rule to honor all of those conversations that took place during the development period. Allowable product types include dried whole fungi, ground homogenized fungi, which can be encapsulated or stirred into teas. We also allow extracts and edible food products. We do partner with the Department of Agriculture here in Oregon for any extracts or edible food products. They also have oversight over anything that's the extract or edible food product due to food safety laws. Throughout the process, psilocybin products will be tracked in a product tracking system, and this includes manufacturers, laboratories, and service centers. And product tracking ensures accountability and helps to prevent interstate commerce or diversion, which is prohibited by the statute. And finally, the laboratory license. This is for the premises that will test for species identification, product potency, and solvent testing if they're using methanol in cultivating or processing extracts. And labs must be accredited by the Oregon Environmental Laboratory Accreditation Program prior to applying for a license, and that's a condition of licensure in our statute. All psilocybin products must be tested by a licensed laboratory prior to the sale, and testing results must be entered into the product tracking system, as I mentioned. Our section can also request additional testing. So if we have a feeling that we need to test for, heavy metals, pesticides, or microbials, we can absolutely do that. We work with our partners at the Oregon Department of Agriculture, and we can also ask for third-party validation testing if we're sensing that we need to verify some of the potency testing. I do want to comment on that. Unlike cannabis, no one's really trying to strengthen these products. They're tested. I mean, they may be trying to improve the products, but they have to be tested and labeled and packaged based on the potency. And so, in many cases, cannabis has reported over time, the industry has dealt with issues with trying to spike the potency. And in this space, it's really important to understand what that potency is because of our administrative rules, and also to ensure that the client has a safe experience. So in addition to these 4 license types, any employees that perform work on a licensed premises, or if they're licensed facilitators providing psilocybin services, they all must apply for and maintain worker permits. And all worker permit applications and license applications require criminal background checks. So every person that's licensed or permitted under the Oregon model passes a criminal background check. And so we began accepting applications for all 4 license types on January 2nd of 2023. And we began issuing our first license in, I believe it was March, and then we had all 4 license types licensed by summer of 2023. And then that's when service center doors began to open to clients. And as of September 6th, which is today, we've issued 356 facilitator licenses, 31 service center licenses, 13 manufacturer licenses, 1 laboratory license. We've had 2, but the other laboratory did not renew. We've issued 673 worker permits, and we've approved the curriculum. We currently have 25 training programs with curriculum that's been approved by our section. So I'm going to go ahead and move forward with explaining the 3 components of psilocybin services. And again, this includes preparation, administration, and integration sessions. All 3 components are facilitated by a licensed facilitator. A preparation session includes a client intake, a review of informed consent, client bill of rights, accessibility needs, safety and support planning, transportation planning. And it really is a time when a licensed facilitator determines whether or not they can provide services to a client and whether the client still wants to continue after going through all of the documentation and learning more about what to expect, the risks, the unknowns, et cetera. And just on a side note, facilitators can decline services to a client for any reason in our administrative rules. And also there are certain diagnoses or situations where a client would not be eligible to access services. And I'll just quickly mention that those include if they have ideation of harm to self or others, if they've taken lithium within the past 30 days, and also if they've been diagnosed with any kind of active psychosis throughout their lifetime, which is really difficult. We understand the challenges to those three, and we also have many limitations with research and information available. And so that's why it's so important for licensed facilitators to be able to decline services to a client if they don't believe that they're appropriate for services. And they may decide to refer to another licensed facilitator that might have more experience working with that specialized or unique issue that the client is experiencing. After the preparation session, a client may participate in an administration session at a licensed service center. The administration session is the only time a client can purchase psilocybin products, consume psilocybin products, and they have to stay at the licensed service center for a minimal duration of time based on the dosage that they consume. Again, I've already mentioned this, but facilitators cannot touch, handle, sell, administer psilocybin products to clients, and their role is to support clients through the duration of the administration session with harm reduction principles and other skills that they learn in their training programs. Clients are required, like I said, to stay at that service center, and there is a release process. So both the client and the facilitator have to agree that that client can be released from the session. And I'm sure you have lots of questions about that, and I'm happy to answer. They do have to provide emergency contacts. So if they refuse to sign that release or they leave the service center, the emergency contact is contacted. And service centers are also required to report anytime emergency services has to be contacted to us as well. We'll talk about that in a little bit. So licensed facilitators will follow up with clients within 72 hours of an administration session, and clients will be offered integration sessions, which are opportunities for additional safety and support planning, providing clients with information on community resources, peer support networks, other integration opportunities, as well as being referred to providers if they don't have one. So maybe, they need to go into counseling or they need to access therapy. That would be a time that that suggestion can be made. We understand that it's not just the psilocybin product itself, but the setting, and the support through preparation, administration, and integration that are really foundational to safe services and effective services. I want to talk a little bit about training programs. Individuals who plan to apply for facilitator licenses must complete the OHA-approved psilocybin facilitator training program as a condition of licensure. We don't have the statutory authority to license and regulate training programs under our statute. So there is a state agency, however, that does. That's the Higher Education Coordinating Commission. They license and regulate training programs. If you could mute yourselves, that would be fabulous. Thank you. So the Higher Education Coordinating Commission does license and regulate training programs if they're subject to the definition of career training school or degree granting program. And that's really a consumer protection regulatory structure, as well as if a training program does go out of business, there's an insurance fund to cover, to cover that issue. I don't work for the Higher Education Coordinating Commission, but they do have a very structured consumer protection framework for training programs. And I do want to mention that we work together as partners, and training programs are something that we have a lot of room for development and growth. And when we first started off adopting rules for training programs, we really leaned in to the recommendations from the Oregon Psilocybin Advisory Board and the Training Program Subcommittee. But we also recognize that we need to grow this training. And so continuing education units, maybe more rigid or strict modules, extended opportunities for students to actually get hands-on experience. These are all issues that we're working on, and some of these are actually statutory changes that we need to make. Others are rule changes that we're actually working on right now as we're in rulemaking. Happy to answer any questions you have. Again, the facilitator training program requirements were adopted from the recommendations by the Oregon Psilocybin Advisory Board, whose members conducted research on psilocybin training programs that had existed in the US and worldwide for many years. And the requirements consist of the core training and practicum and consultation hours, and are comprised of modules, including but not limited to historical, traditional, and contemporary practices and applications, cultural equity in relation to psilocybin services, safety, ethics, and responsibilities, and many, many others, including training on psilocybin. Administrative rules outline minimal requirements. The development of best practices and standards for facilitation is underway in Oregon by members of the regulated community. But again, the development of best practices happens over time. And so our administrative rules are the minimal requirements. We will inform those requirements based on best practices. However, we leave the minimal requirements so that we can support public health and safety, as well as flexibility in the model. There might be facilitators that specialize in sexual or domestic violence, someone that might specialize in, supporting race-based trauma. Some folks that might actually focus on refugee or immigrant traumas, or for veterans who are seeking support for trauma. It might also be facilitators that support people because they're curious or experiencing grief or end-of-life anxiety. And so we want to leave some flexibility so that that specialization can grow and develop. We've listened to feedback from many partners and work with the advisory board, rules advisory committees, and the public on continuing education and other requirements. So we're going to be developing that over time. I'm going to talk about facilitators quickly. Our Oregon model creates opportunities for a new workforce in Oregon, and specifically for licensed facilitators that represent diverse backgrounds that can support their communities through culturally responsive and equity-centered services. My dad's a Vietnam veteran, and we talk frequently about how if he was going to access services under this model, he would want a combat veteran to support him as a facilitator. And that illustrates why culturally responsive services can be helpful, reduce additional trauma experienced during a vulnerable state in a psilocybin journey, and also really help people feel comfortable as they're coming in. Licensed facilitators that represent those priority populations in our state health improvement plan can really help clients and help align with public health and safety goals that we've worked with to identify what priorities are, as we did work with communities for the development of our state health improvement plan. If you are interested, Healthier Together Oregon is the name of the state health improvement plan, and I highly recommend that you check that out. It's a really incredible body of work, and it's something that helps us tether our goals and align our goals with that body of work. So providing opportunities for lineage and legacy practitioners is a big question that we receive. It's foundational to centering equity. We know that Indigenous communities have had a relationship with psilocybin for thousands of years. And we also know that there's a lot of knowledge and wisdom that comes from that practice. But the challenge is how do we define what a lineage and legacy practitioner is? How do we even define Indigenous? Is it the state government's role to do that? No. And also, how do we create criteria that does not cause harm to communities or clients accessing services, and also evaluate evidence that a practitioner meets those criteria? So because we've been challenged by this, we created a pathway and administrative rules for allowing psilocybin facilitator training programs to offer very specific accelerated training credit to students for lineage and legacy experience. And this can be awarded based on professional credentialing, prior training and education, relevant experiences such as established plant or fungi-based healing traditions, et cetera. And they're only allowed for certain modules and they don't apply to practicum. So that's important to note. Also, reducing barriers for licensure is important. And so although currently we can license folks that hold dual licenses, and many people do hold dual licenses, as we're working with our licensing boards in Oregon to really collaborate and understand how to move forward effectively together, we don't allow those folks to practice on other licenses while they're providing services. All of that said, we've got some movement coming where with a statutory change, possibly next year, we'll see if that happens, that helps provide protections to dual licensed facilitators. We can then open up our rules and allow folks to practice on their dual licenses as long as administration sessions are non-directive. So that's something that we're working towards, and would love to keep you updated on how that goes over time. We don't want to create secondary and additional licensing structures that could be complex and also expensive to implement because we're a fee-based section and the cost of licensing fees has to cover the cost of our section's work. Therefore, we want to try to make sure that we're able to provide equitable licensing fees. And we'll talk about that briefly in a moment. I want to kind of wrap this up so you can ask questions. And so I think it's important to highlight again, licensed facilitators can decline services to clients for any reason. And they can refer them to other facilitators. And we truly believe that building a strong network of facilitators with diverse lived and professional experiences will create opportunities for aligning services with client needs. Some clients are going to come in the door and they're not going to have complex diagnoses or any diagnoses. Others will. And so how do we ensure that we're creating a model that's safe for everyone and also flexible enough to, allow for lower dose administration sessions that are subperceptual, higher dose administration sessions that are hallucinogenic, and also ensure that we're developing safety, throughout the process. So one of the most important factors in ensuring client safety is the licensed facilitators' interaction with clients, their understanding of their own limitations, and working within the rules and their scope of practice and level of expertise to identify potential safety risks and support the clients through services. And our administrative rules, again, provide a very important framework for safety and very minimal, not very minimal, but the minimal requirements. Trust me, there are hundreds of pages of rules, but it's really the licensed facilitators, all of the work and their own self-awareness, their own professional awareness, their limitations, and working within the scope of practice, coupled with the service center's operating guidelines that will really help create safer and more effective services. So we try in our rules to create requirements for service centers and facilitators to be communicating together. Our section will investigate complaints, incidences, or concerns related to safety issues or statute and rule violations that occur on a licensed premises or during the provision of psilocybin services. When we receive a complaint, we'll determine through investigation if there are potential violations of our statute and rule, whether we're the agency that has jurisdiction to take further action, and after investigation to determine if there's truly enough evidence to move forward with an administrative violation. So complaints related to criminal activity are a matter for law enforcement, and complaints are also subject to public records laws. And so we allow for, if complainants are concerned about their safety or confidentiality, we'll make every effort permitted by law to help keep their identity confidential. During an investigation, we conduct interviews with complainants, witnesses, and licensees involved. We'll request client records, security footage, visitor logs, whatever it is that's relevant to that investigation. And of course, we'll go through the Administrative Procedures Act process, and sanctions depend on the severity of the violation. It may include restriction of a license, civil penalties, suspension or revocation of a license, and a licensee will have a specific period of time to request a hearing. If they do, an administrative law judge will determine the final order through a recommendation, and then we'll proceed forward. Any member of the public can file a complaint on our website, and so we've got information there. I'm just going to share some stats on complaints. As of September 3rd, we received 41 complaints. We currently have 8 open cases, open investigations. And as of September 3rd, and this is an important data point, as of September 3rd, 12,699 psilocybin products had been sold by licensed service centers to clients for administration sessions. And while some of those are secondary doses, we know that a significant number, in the thousands, of people have been served under our model. We also know that there have been 4 reports to emergency services being contacted for precautionary reasons. We think support for licensees is very important. The Oregon Psilocybin Services Act was passed by Oregon voters. It did not provide additional funds for licensees to subsidize cost of licensing fees, to help them start their businesses, to fund students that wanted to be trained in training programs, or even to help really fund and subsidize the cost of our services. So it's important to note that that financial, the fiscal cost and the budgetary cost, it's really important for us to think about equitable licensing fees. And so across all of our decisions, I've made decisions on how to organize and structure our section, how to appropriately partner with other folks that have infrastructure in place so that we can reduce cost and rely on them for their expertise, such as background checks. We don't actually process background checks. We've partnered with the Oregon Background Check Unit, who does tens of thousands of background checks and also works on a weighing test so that those folks that have been previously incarcerated or have conviction records may not necessarily be disqualified, but the level of risk to clients and kind of their background and history is an important part of that weighing process. And that way we don't have conviction history in our records, and it's part of institutional bias, a part of our state health improvement plan, a goal that we're working toward, as well as equitable licensing fees. So we've really done a thoughtful job, an intentional job of building our section out. We are a health-focused agency, not a business-focused agency. So we've partnered with the Office of Small Business Assistance to identify business supports and resources for those folks that want to be licensed. Many folks have a big heart and great intentions.
I'm sorry. I know we do want to get to questions. Do you have materials that you can send me in writing?
Absolutely. I'm happy to do that. I did not know I have an hour blocked out, so I had a 40-minute presentation and Q&A. So I'm happy to stop and turn it over.
I'll leave it up to the members. Do y'all want her to continue with the rest of her presentation? Dr. Shad, I see you talking, but you're on mute.
She has 40 minutes left. There's only 4 minutes left in 40 minutes, and then we can open for questions.
Okay, so yeah, go ahead and we'll let you complete your presentation.
No problem. Thank you. So I'll just kind of move through this a little bit quickly, but I will say on our website, we have the business resource directory. It's really important that people understand BOLI, OSHA, and other requirements if they're going to be successful in their businesses. There are equity, access, and affordability issues. Again, we've talked about how we're a fee-based section. We do allow reduced fees for low-income Oregonians that want to be licensed under the model, or for veterans. And we require social equity plans for every licensee. We've got information about that on our website, and I'm happy to share that with you. I do want to just say we understand that these practices did not begin with the latest research, interest in research and the passage of legalized frameworks, and for thousands of years, Indigenous and some tribal communities have had a cultural practice. And so we are holding on to 2 very important truths, and that's holding on to the cultural and anthropological information available to us. We do convene community circles with Indigenous folks. We do work through our government-to-government relationship with the 9 federally recognized tribes of Oregon, and we do offer opportunities for people from federally recognized or non-federally recognized tribes to convene with us and share feedback. But we also are holding on to the scientific information and research. We do have that posted on our website, and our board is updating that research. So we'll have some more updates in the coming months, and we're excited to share that with the public. I just want to say that we work with community-based organizations. We're developing systems. We have a cloud-based licensing system that's very important for efficiencies. And ultimately, it's really important to us to transform the health of our communities through safe and equitable and accessible practices and a deep respect for the history of psilocybin, as well as safety and new research and information that's made available. You can join our distribution list. We have over 14,000 folks that subscribe. We send out quarterly newsletters. We have lots of information on our website. All of our client-facing forms are under I want to access psilocybin services. Those are in English and Spanish. We always provide Spanish and American Sign Language interpretation, as well as cart captioning. So for any of our public meetings, we offer those. The public listening sessions and public hearings on rules. And we just encourage you to reach out if you have any questions. And again, I'm happy to share our website. I don't know if you want me to do that in the chat box or, what you would like for me to do if you just want me to follow up with an email, but happy to do whatever works for you all. And if you have time, I'm happy to answer questions. If not, I'm always happy to, if you want to collaborate and send those out to me, I can follow up with some answers. Thank you.
So I think we have a few minutes for some questions. So members, if you have questions, raise your hand. Or go ahead, John.
Thank you. A wonderful presentation. I appreciate it. I listened to the part on the indigenous community, and I was a little confused. So I heard that you recognize, and I appreciated everything you said, but it also sounded like you were licensing in a dual license kind of format could you explain that a little bit more for me?
Absolutely. Thank you for the question. So we only have one license type for facilitators, but people they can apply even if they're licensed by other Oregon licensing boards. So there are many different models, like Colorado has a model, we have a model. We don't have a separate licensing structure for dual licensed folks. And so that's kind of the difference. People can be dual licensed and apply for a license under our model. They just can't practice on that other license type right now until we work with licensing boards in Oregon to help kind of ensure that there are protections in place for them. We've been working with those boards since 2021. The piece about Indigenous, really engaging with Indigenous communities, as well as the 9 federally recognized tribes in Oregon, and those tribal members that come from many different tribal or Indigenous lands that live in Oregon and outside of Oregon. We offer community circle spaces where we convene with them in a way that meets their needs, and also so that they can provide information to us. And it's been really valuable if they don't want to show up in a public meeting, but they do want to share information with us, that we allow that to happen. And we work through our government-to-government relationship with the 9 federally recognized tribes in Oregon as a state agency to determine whether or not they want to engage with us. And then separately, we also provide opportunities for tribal members or people that are part of tribal or Indigenous lands, to engage with us and also share, if they have had any relationship with psilocybin, any of their thoughts or information as we continue to evolve and build the model. Is that helpful?
Yeah, that's helpful. Thank you.
Yeah.
Appreciate it.
Dr. Shad.
Yeah, Angela, it's good to see you because I was in Oregon at OHSU, so I have some roots from Oregon. So I just wanted to ask you some practical questions about the dosages. You told me that you are using micro dosages as well as the higher dosages. And so is there any kind of criteria when you go from the low level to the high level, and are they more treatment refractory patients in which you are using higher dosages? And also, I don't want to make it a very complex question, but are the antidepressants, if the patients are already on antidepressants, are they allowed?
Great questions, and I love the complex ones. And please reach out if you want to get more granular with me and just have a meeting, because I'd love to talk about this. In very short, very brief terms, we measure psilocybin potency in psilocybin analyte. They do test with a full panel of psilocin that's naturally found in psilocybin, as well as co-occurring compounds, baeocystin, norbaeocystin, and others. But because of degradation that happens very quickly with psilocin, we allow people to put the total potential psilocin on the label, but we measure in psilocybin analyte so that we, have a specific number that aligns with our rules for how long they have to stay at the licensed service center. Many times it's much longer. There's no weight, age, or other way that really you can say this dosage is tied to this weight or this gender. People respond differently to psilocybin, and there's a lot of limitations in research to understand why. We do allow, like you said, the lower dose to higher dose. We have a maximum of 50 milligrams of psilocybin analyte. That's rare. That's not standard. We don't encourage it. However, some folks that are on SSRIs, when they go through informed consent, which you should definitely read, we have a lot listed about the limitations and the unknowns and the potential risks. And we also ensure that clients know that our facilitators are not pharmacists or physicians in these roles. And so, I think it's really important that they understand that we don't have information about contraindication yet that's very clear. And so folks on SSRIs have been known to not feel the effects of psilocybin and have gone up to a higher dosage. We're working with our board and the physicians and lots of folks from OHSU, who are on the board to determine if there's enough research to create additional conditions for ineligibility. But the board decided to keep it as open and flexible as possible to avoid any kind of discriminatory practices until we have more information. And that's why the emphasis on informed consent is so important. Would love to follow up with you, though, because I could talk for days about products. So thank you.
Yeah, if I can ask some follow-up on that, I think using SSRIs with psilocybin is a major issue because both work on the same receptors and the same systems. And it seems like when you give SSRIs, there are some receptor downregulations and upregulations depending on which presynaptic and postsynaptic receptors you're talking about, which actually makes mute or kind of dampen the effect of psilocybin because it is kind of a partial agonist at one of those receptors on which SSRIs are also working. So I think that is I really like that because it seems like you know all the very kind of underpinnings of all the difficulties and problems you have, right? Just one more question. Do you know why lithium is contraindicated?
This is research that was found by a physician that serves on our psilocybin advisory board. And I do want to encourage, if you do have research that you'd like to share, if you have any concerns, we are very excited to review that and review that with our board members. So please feel free to do that. We're learning along with everyone across the globe. And it's really important that, we're ensuring client safety. So yeah, that's where that came from, is a physician that brought that forward and was concerned enough with it and had enough research that we decided to make that a condition for ineligibility. And it's lithium for 30 days. So we've been told that after 30 days, then the lithium shouldn't be in their system and it shouldn't be an issue. But we're not encouraging people to go off of their medications at all. It's just a matter of ineligibility. So.
The last thing I would like to say is that when you use medication, antidepressants, which actually block 5-HT2A receptors, I think that can actually interfere also with the psilocybin efficacy. And there are some of them out there. So I think the public awareness and the physician awareness, because I'm a psychopharmacologist, I know some of these things, but not everybody kind of appreciates this. So it's very exciting. Thank you very much for your very, very nice presentation. Thank you.
Thank you. Please stay in touch.
Yeah.
And I would just also say, if you have additional research or information, we're really looking at the contraindication pieces as we continue to open our rules every year. So thank you.
Thank you. Thank you.
Josh?
Hey, thank you very much for your presentation. There's a lot of information I'm learning from that too as well. I just had a question from a law enforcement perspective. I know you gave the numbers of complaints you had. Does those complaints include police response to a facility, or do you have that number? Because that's going to be the concern of my agency is how many calls for service and what were the problems at that facility?
Yeah, these are calls that are made while a client is on a licensed premises. So it might be that a client is nervous and has anxiety and they want to take anxiety medication, or they go to the restroom and they take it and then they come out and the facilitator finds out and says, "Oh," I mean, I'm just giving random examples, but like it could also be if someone gets violent in the middle of their session and, emergency services need to be contacted. There could be so many reasons. And so what we do is we encourage our licensees to make sure that they're trying to reduce harm and use their training to support the client, but then call emergency services if needed. The law enforcement piece is really interesting. In our model, we have a law enforcement hotline and local government hotlines. So if law enforcement are out and they're getting ready to serve a warrant and they want to check in to make sure that it's not a licensee that they're serving a warrant to, or if they're like, hey, giving us a heads up that they have a concern and they want to, like, it's also helpful for us to know if there's a criminal activity happening on a licensed premises that hasn't been reported to us. So we have that hotline, and we've had, various folks from law enforcement, different partners that call in, and, we can only tell them if the address that's listed is a licensee or not, or if the person's name is, tied to that licensed premises. But even so, it's really the address. As far as emergency services, we receive that information and, that there's an emergency report. And if there's something more extreme, we like to follow up and find out what happened just to help create more safety in the model. So far, it's been precautionary is what we've heard from those calls, haven't led to, basically to hospitalization or to any kind of fatality or any kind of, law enforcement criminal intervention. It's mostly also if someone just decides to leave, the emergency contact isn't answering, that's another opportunity. So there's like limitless ways that emergency services could be contacted. There's been 4 times, and most of the time our licensees develop relationships with emergency response providers in the area. So that way they've already established a relationship and they're already aware of one another. So
Okay. Yeah, I just know that in the state of Nevada for our dispensaries, if there's a call for service there, they have to notify the Cannabis Compliance Board. I was just curious if there's something set up there in Oregon as well for something like that.
yeah, not really. I mean, our licensees have to report, and then we have the hotline just to help support
Okay.
law enforcement, to make sure that they're not serving a warrant to someone that's licensed legally in Oregon to, to manufacture psilocybin. But if there's issues about diversion into the unregulated space or interstate commerce or not following our statute and rules, then of course we're going to partner together.
Perfect. Thank you.
Yeah, thank you.
Terry?
I echo my committee members. Thanks for your comprehensive and informative presentation. But my question kind of revolves around, you've been in operations for well over a year, and you talked about having the culturally competent facilitators. And I just wondered, over a year, are there any specific groups that you are needing more facilitators for? And how do you really solicit and get those facilitators if you're needing more, or if there's a certain area that you're lacking in for those facilitators? Thank you.
Thank you. Great question. So, 2 quick answers to that. One is we know we have folks that are veterans. We've got some folks that are licensees that provide services that come from certain communities that are people of color, Indigenous community members, and have openly, publicly identified. We don't currently collect the race, ethnicity, language, disability, sexual orientation, or gender identity of licensees or applicants, but Senate Bill 303 was passed in 2023 by the Oregon legislature that requires licensed service centers to report certain client information, including race, ethnicity, language, disability, sexual orientation, gender identity, as well as reason for accessing services, how many folks have been denied, the reasons why, any adverse events, whether that's medical or behavioral or severe medical or behavioral, meaning hospitalization. They report those aggregated data to us on a quarterly basis. And then after the first quarter of 2025, you can visit our OPS data dashboard and you can see all the data points. We're also going to pull that together in certain pages, one for licensing, one for compliance, one for safety data, and then one for demographic data. So to that point, you'll be able to visit the demographic data page and see aggregated data that's been de-identified and meets publishing standards for our agency for data, but also that identify certain community identities based on that law that was passed for applicants, licensees, and clients. We do know that veteran data collection might be something that's coming, and I think that there's a lot of folks from, disability communities and other communities that, have a strong interest, hospice, and end-of-life care. And so I think that we're just beginning, and because we're first in the nation and we have a small team, we're small but mighty, we're really trying to make sure that the members of the public, all of our state colleagues and partners have this data so that we can make informed decisions together. So look out for that. And I would say that we're just scratching the surface when it comes to culturally responsive services. And I think when you think about the layers of identity and how important it is to support someone that's experiencing, intersecting identities and what they've been through, I think it's, we're never going to have enough representation. But I think if we're making that a goal and a part of our work, then that focus is going to build the table even more. Thank you.
Thank you, Diane.
Yeah,
And I believe this will be our last question.
Perfect. Diane Goldstein, Executive Director, Law Enforcement Action Partnership. Angie, thanks for the great. My questions are actually simple. Have you worked with both law enforcement and fire services, mental health services to provide first responder training or develop first responder training on the potential of someone, comes in and has a bad reaction, similar to like what Denver did, is number one. And then are you guys tracking arrest data pre and post regulation as a measure of an outcome to show how, regulation is in fact working or not working?
Great questions. We only have the statutory authority to do the work that's in the Oregon Psilocybin Services Act, ORS 475A, and our legislature only gives us position authority and resource to do that work. So as much as I would love to capture data outside of what happens within the regulated model, that's not something that we currently have the capacity or the authority to do. And so I would love to, and again, we're trying to build bridges. Like, we know silos don't work, and we know people are going to access psilocybin. So if they're accessing it in the unregulated space, there's a lot of concerns about abuse, safety, and other issues, the legal issues as well. And so, how do we look at how the regulated model has an impact on, sort of encouraging folks to work within what's legal? There's so many questions out there. We have provided presentations to law enforcement. We're working with the Chief Medical Officer Examiner's Office to do a presentation. We're always open to doing presentations. We've done hundreds of them to community-based organizations that are part of the public health system. Terry, this goes back to your question. We provide organizational trainings to anyone that asks. We will always present, provide meetings and information. We have 170 community-based organizations that are part of our public health system that deliver services to their communities. We present to them, as well as folks that are not part of those CBOs, and we work with state partners and others. And so we have done presentations, and we're always open to doing more. We are going to build a physicians page on our website that has the scientific literature review, which is in English and Spanish, and the cultural and anthropological information. information that the board has gathered. And then also just information like here are the forms that clients are going to be filling out in this model. And, also just building a bridge. And we do have physicians referring clients into services now, and providers, clinical providers as well. And so we're really starting to see kind of more of that happening. And we'd like to really make sure that we're partnering together and listening to feedback from, all the perspectives, because this is one policy area. It's not just like health. It's medical, clinical, non-medical, clinical. It's holistic. It's really looking at cultural identities, indigenous, tribal, folks. It's bringing people into the conversation that might not have access or have been served by the model. Criminal justice, human services, healthcare, and so it's really like the culmination of lots of policy issue areas, and you'll see that in our rules. Client support people that help folks with toileting, mobility, and other issues that are not facilitators that clients can bring in to support them for those specific needs. So things like that we've tried to weave into our rules. And so if you're interested in the riveting 100+ pages, please feel free to review those, and always happy to share more information. And just thank you so much.
Thank you so much, Angie. We really appreciate it. If you wouldn't mind, before you leave, posting in the chat the website so that we can have people have access to that. And then, of course, if you could send me your written comments or any materials you had, that would be helpful for our record. So thank you again.
Thank you so much.
Okay, next is items 6. We had scheduled Lori Bratton with the Natural Medicine Board, State of Colorado. Unfortunately, she's not able to present at this meeting, and we are intending to have her present at the next meeting. So we will go to item number 7, Dr. Shad, on a discussion of the neurobiology of psilocybin response and the differences between SSRIs and psilocybin responses. Dr. Shad.
Thank you very much, Marla, for giving me this opportunity, because, some of the reviews and the paper I've written with psilocybin actually is kind of very interesting findings. But before we go there, I just wanted to give you a background, because since I am a psychiatrist, I think it's my responsibility to provide you some of the other stuff which is going on, which could be highly relevant. It is such a huge topic that having a few minutes of presentation time is not going to do justice, but I'll try to do my best. So I think, as we know, historically, what happened is that with the discovery of ketamine in the treatment of depression, and kind of bringing kind of a revolution in the treatment of depression, and the revolution being that it is the only antidepressant which actually results in a rapid antidepressant and rapid anti-suicidal effects, which we have never seen before. So this, and since ketamine is considered by some people as one of the psychedelics group drug, it actually opened the door for other psychedelics to be investigated, because people were excited, and the research on psychedelics has been kind of for years, for decades, has been obstructed. I don't know whether politically or for some other reasons, but now I think the ketamine actually discovery has opened the gates for further research in this very interesting area of drugs, which can be effective in the treatment of depression in a kind of a different way, in a kind of a novel way, which we have never seen before. At the same time, I will talk about the caution and a very safe approach, that is part of this, and I'm not going to miss on that. But let me just tell you about a little bit about one of the study which all of you would know is getting a lot of press these days, is the MDMA assisted psychotherapy for the treatment of PTSD, right? And some of you might have read that the advisory group of the appointed by the FDA actually did not recommend approval of MDMA assisted psychotherapy. And some of the reasons which were given is that the study design had some problems. So I just very quickly wanted to tell you some of the problems with the study design, so that in a way we are informed that when we are doing research on some other psychedelics, including psilocybin, we actually take those points into consideration and use them as a guidelines. So basically, uh, the one of the concern was that uh, that there was a failure in the study design to compare between the psychotherapy effects and the medication effect, right? So that is one of the concern. Um, and and the company, the Lycos, which is the name of the pharmaceutical company which was doing the trial, actually said that when they conducted the analysis, the end of the study's analysis, they found that there was no difference between those who had psychotherapy versus the group which the placebo actually was discovered that although there were differences, meaningful differences between the two groups, active group and the placebo group, but they found that the patients who were kind of drug naive and the patients who had been using MDMA before, actually there was no difference between the treatment response. So that was the argument that they were not able to differentiate between the two. They also, there was a concern about functional unblinding. Functional unblinding is a technical term which is used when you are using substances or medications or drugs or equipments which actually make it very difficult to maintain the blind. And so the company actually responded that the way they dealt with that unblinding problem is that they had third party raters, raters who actually were not informed about anything about the patients that which group they belong to. So they actually addressed that. And another point was that there was one incidence of violation of boundaries, which they actually explained that they took care of that immediately. And there was one therapist who actually was involved in that, and they put in some safeguard to protect from future violations. And but another thing which was found in the study was that we understand that if a clinical trial is occurring at multiple sites, there are some site differences in results, and that's a not so uncommon. A lot of randomized clinical trials, preclinical trials which are conducted by the pharmaceutical companies actually show some differences in response rates across different sites. But this study, they reported in their study results that there were no any clinically meaningful or statistically different results across different sites, which actually suggests actually that the findings could have been valid from this study. So that was a little bit about MDMA assisted psychotherapy. The main issue is that since the advisory board has actually not recommended the approval of this strategy, in most cases FDA follows their recommendation. So I'm not very hopeful that this strategy will be approved at this time, but you never know for sure, because there have been some instances where FDA has approved those medications which were not recommended by the advisory board. So that is a little bit about MDMA. But my focus today is more on psilocybin. Um, uh, and psilocybin, but before I go to that, there's another point I'm sorry I missed, that the adverse effects with MDMA were also raised in some of the issues with the study. So I just happened to see this latest meta-analysis just printed in 2024. So the issue was that there was some concern about hepatotoxicity, which is liver problems and cardiovascular adverse effects. But this meta-analysis is just very recent, Actually, it did a comprehensive analysis of all the adverse effects from all the studies which have been done with the psilocybin, and they found that the adverse effect profile of a single dose of psilocybin appeared quite tolerable, and most adverse effects were resolved within 48 hours. But I think still we need to be careful about this, because this is one meta-analysis, and maybe the future studies will tell us a little bit more. But at this time, this is all we have. Uh, so that was about MDMA. Let's go to psilocybin. So, and also one point I wanted to make is that in their new drug application, the pharmaceutical company actually did want to have REMS guidelines. REMS is a monitoring system which actually used for multiple psychotropic medications. It's called risk evaluation and mitigation system. And so the recommended, if this drug gets approved, this MDMA assisted psychotherapy gets approved, then they would like to have a REMS monitoring system. Anyway, so so basically there is another psychedelic assisted psychotherapy, which is psilocybin assisted psychotherapy. We had a lot of good information from the lady from Oregon. So we had, I had included some Oregon information, but I don't have to talk about it now. So my presentation will be much shorter. We'll leave some time for the questions. So psilocybin actually is mostly used in microdosing. And the reason why microdosing is the most desirable dosing strength for psilocybin is because the majority of studies, the one I have reviewed, regardless whether there was neuroimaging done or they were just clinical trials without neuroimaging, I have found that 25 milligram was the most common dose used psilocybin, perhaps in most studies couple of times within interval of about a week or 10 days. Most patients received a couple of dosages, and that's what we call as microdosing. Anything beyond 25, especially 50 milligram, can be called as a trip dose, which cause hallucinations. And one of the thing I wanted to tell at this time to the group is that the microdosing has not shown any addictive properties as far as we know, and there's a lot of data actually does not support that it has any addiction potential, right? So those are some of the facts. Now, in terms of psilocybin, let me give you that some of the aspects of the clinical research which has been done so far. So there have been 11 psilocybin trials, and I am not going to give you the details of those because it will take a lot of time. And 257 patients have been studied in those 11 psilocybin trials, all used microdosing. And I think Jennifer told us from Oregon Angela told us from Oregon that they are still they are not doing any data collection in terms of the response and the efficacy and the tolerability, but there is a non-profit advocacy group in Oregon which is actually gathering information from the patients who are being treated in Oregon. And the last number I saw was about 750 subjects, which is much more than 257 which had undergone clinical trials. So I think it's still too early to say anything about what is the potential and what are the effects, adverse effects, and efficacy of psilocybin assisted psychotherapy. And so that is based on the Oregon data. But the Oregon data actually, which we didn't talk about much, is that they have actually, based on their experience so far, they actually highly recommending the environmental environment which is more conducive to have a positive psilocybin experience. So they're talking about highly controlled environment with the facilitator who provides very safe and relaxing environment with ambience, with some artwork and some soothing colors and things like that, along with a very comprehensive psychiatric evaluation and also detailed medication history, which is extremely important. As you remember, one of my questions was whether patient is already taking antidepressants and whether that antidepressant is going to interfere with the effect of psilocybin, then the whole experience is not going to be worth it, right? Um, the other thing which I have heard a lot from my colleagues and people who are interested in this molecule and talk about and talk to the people who have actually have used it, it is a very common knowledge now that if you really want to do a psilocybin assisted psychotherapy, you want to make sure that the patient is in a quote good space unquote, because if you're doing psilocybin assisted psychotherapy in somebody who is angry already, who is irritable, and who is in a bad mood and having some really stressful time, actually psilocybin therapy sometimes can backfire. And so we have to be really careful about that. Now, since I'm a neurobiological psychiatrist and I've done neuroimaging studies and I've done genetic studies, and I really love to look in detail about mechanism of action of drugs. And that is one of the reasons why I write this paper on psilocybin. So I just wanted to give you the highlights of what I observed very simply in a kind of a not a very scientific language, just to make it as simple as possible, right? Um, so, but before I start on the neuroimaging finding, let me give you a kind of a statement in which I would like to inform you that I want to say very clearly that there's no cause and effect relationship between neuroimaging findings and clinical effects. We all know that, right? But some of the things which I've seen, some of the exciting and interesting effects of psilocybin on the brain system, actually the reason why I got curious about this is because when I saw the changes in the neural substrates after psilocybin treatment, I just realized, it dawned on me that psilocybin acts completely different from other antidepressants. And that is something which I found so fascinating that I want to do a more detailed dive into the mechanism of action of psilocybin. So basically, let me give you some of those, not in detail, but just to tell you. So we know that SSRIs and some of the other antidepressants, there are many mechanisms of action which actually people have hypothesized that they may result in antidepressant response. But one which is very commonly talked about is that SSRIs actually deactivate or decrease the activation of amygdala. What is amygdala? Amygdala is the fear center of the brain. And so when SSRIs go and decrease the activity of amygdala, your fear is decreased. The painful element of your thoughts, your experiences, and the trauma are taken away, right? So that is one of the putative mechanism through which we believe SSRIs helps in treatment of depression. But very few people know that there is a price to pay for dampening the activity of amygdala, because it's not a one-way traffic. So it is true that decreasing the activation of amygdala is good for causing a kind of a more tolerance to the stress and the things, stressful things happening around you, and also the fear element associated with depression. But at the same time, the patients are losing the ability to feel, to be emotional, to be empathic, to be sympathetic, things like that. Why? Because when you make amygdala numb, it also induces emotional numbness. And if you look at one of my papers, which I recently wrote, I can give you the link for it, that SSRIs actually in a lot of patients induce emotional numbness. And the problem with emotional numbness is that although you feel kind of, you can survive, right? But when you lose the empathy and the emotional aspects of your relationships and loved ones and your interactions, then it becomes a social problem. And a lot of patients who come to the clinics will tell you that, Dr. Shah, I know I am not as anxious and depressed as before, I can tolerate the pain and suffering a little bit better. But I feel like I am losing the ability to love people, to have meaningful kind of expression of love and affection to my loved ones, right? And that is not such an uncommon thing which is seen with SSRI. So the moral of the story is I wanted to build this kind of a climax to tell you about what psilocybin does. Psilocybin actually activates amygdala. What a striking difference. Psilocybin activates amygdala, and one of the reasons why the researchers actually believe that the reason why it is stimulating the amygdala and what are the clinical consequences of that is that actually psilocybin is desensitizing rather than numbing or decreasing the activity of amygdala. We all know that desensitization is one of the major strategies we use in treatment of behavioral treatment of anxiety disorders. Very helpful treatment, very, very effective. So I think if you use that analogy and combine that with psilocybin activating amygdala transiently, though, not permanently, because that will be bad, right? Transiently, giving a window of opportunity where patients can actually listen to you and change their memories and can reset their brain like a fresh start, right? So that is something which is completely different between psilocybin and other previous antidepressant medications. This window of opportunity does not last for long, and there is a certain time in which you can, if you do psychotherapy, and if you are doing some supportive kind of strategies for the patient, it is the time when the patient listening to you. It is the time when the brain is more conducive to make a change, which is going to relieve their stress, anxiety, and fears, because that is the time brain becomes more malleable, right? If I can say that. So neuroplasticity, which is the ability of the brain to change synapses and connections, actually is much more feasible at that time. So those are the difference. Another thing which psilocybin does, and based on the imaging studies, I don't know whether you had a chance to look at my review paper, but just to make another point and then we'll move on, is that psilocybin actually decreases the functional connectivity between different regions, as if it is trying to create kind of a neural substrate for systems to get together and have a brain reset. And one of the things which I'll tell you is that this is the only antidepressant potentially which actually resembles the mechanism of action of ECT. And we know ECT is the last resort for patients who are not responding to anything. And one of the most effective, actually not one, but the most effective strategy in patients who have given up. They are not eating, they don't have any will to live any longer. And psilocybin actually similarly resets the brain as the ECT resets the brain for a fresh start. So those are some of the fascinating things I found. And the point is that when you look at all these changes, you begin to understand why psilocybin is acting the way differently from other antidepressants, where you have to take daily dosages of antidepressants to maintain the efficacy. But with psilocybin, you know how many times we have shown only two dosages, few days apart, have been functional. In some studies, there was a recent study showed it was effective for 12 months in some patients. You know, I've never seen anything like this. So this is the exciting thing. Now the monitoring thing comes, our concerns come, right? So we have to be really careful, because I'm not going to just tell you the only the rosy picture of psilocybin, but there are some issues. For example, you know, we need to make sure that there is a safe delivery of this system. We heard a lot about the Oregon model, and I think it's really nice that we are not starting from scratch, and we do have some guidelines which we can learn from Angela and her colleagues who are doing this for some time now, since July 2023, I think, because they started this. So they have some experience. So that will be extremely useful for us to have that kind of guideline, gives us a little bit a kind of a easier, to build on that, right? Some of the guidelines, we need to follow is that we need to really think about, I don't know whether I don't think they have done any kind of a REMS monitoring system, but in our working group, we can discuss about the possibilities of having even a more strict and closely monitored system where we can do this. And also in terms of manufacturing of psilocybin, we really need to be careful about maintaining the standard, and also the active principle of psilocin, which degrades in some time. We have to make sure that they are not expired and things like that. We need to make sure that we are training our psychotherapists appropriately so that they can provide that support, and we can make sure that psilocybin increase does not use, because that is the law enforcement concern. And I completely understand that without any monitoring, without any observation, the use of psilocybin, who knows, people out there may contaminate psilocybin with some of the more toxic, lethal kind of drugs, which are not even detected by the UDS. All those measures, because really, if you ask my honest opinion, I really think psilocybin has one of the least kind of risk for causing violent and aggressive behavior, based on if it is given in the right amount, and if it is given without contaminated by other more toxic dosages, which is happening in our city so much these days. I work in the ER, doing a CL, psychiatry service, and every day I see something, UDS is negative, but the patient is just rolling on the ground, uncontrollable. The psychotic is so huge that even the Haldol, Ativan, and Benadryl is not hitting that patient. So these things I understand, but that is why I want to make sure that we work with the legal authorities, we work with the monitoring people, we work with the government, and we develop a system which actually ensures that maybe that to have this strategy in future, because it looks promising, it looks interesting, and we don't want to miss that chance. Thank you. If there are any questions, please let me know.
Thank you, Dr. Shad. Any questions? Dr. Hines. I'm sorry, you're on mute. If you unmute yourself.
I'm really good at doing that. Sorry, apologies. Dr. Dustin Hines, UNLV for the record. Thank you for your report, your presentation, Dr. Shad. Were you able to find any research, some of the toxic effects of psilocybin, at what dose, and simple things like what is the lethal dose of psilocybin?
Yeah.
How does that compare to things like lithium chloride, its toxicity?
Yeah. So basically, it's a great question, because that's one of the things I forgot to mention, that we really need to monitor the dosages. Although we got some ideas from the lady from Oregon that they mostly are using microdosing, and their highest dose is 50 and microdosing 25. So with that range of dose, I don't have many concerns. But once you go beyond 50, there is no guarantee that the patient may not become extremely psychotic, because the hallucinations, they remain vivid and colorful and imaginative for a certain limit. But then when you cross that boundary, those hallucinations can become really, really alarming, negative, and threatening. And so we have to be really careful. I don't know what is the toxic dose, but perhaps based on what I've seen in the literature, it could be kind of starting around 50 to 100, and above that are extremely. But remember, every patient is going to respond differently. Every patient may have a different toxic dose based on their neurobiological underpinnings, and also what medications they have been using before. Like I don't know whether you heard when we were talking about some of the antidepressants can actually neutralize the effect of psilocybin, such as SSRIs, such as drugs which block 5-HT2A receptor, which is the main kind of molecular target for psilocybin to mediate their effects, right? So those are some of the things, but yeah, I cannot give you a very crisp answer on this. I'm sorry.
Yeah. So I guess what I was getting at is we know from the literature that when we look at actual markers like PK, ADME for toxicity, that psilocybin has some of the lowest toxicity. And I think you're maybe confusing psychosis and toxicity. Toxicity is something that happens to the heart, the livers, and we typically use metrics like PK and ADME. And as far as I know, especially compared to something like lithium chloride and other kind of commonly used SSRIs, it's not very toxic at all.
Which one did you say, Dr. Hines? Which was not toxic?
Psilocybin.
Psilocybin, yeah. No, I completely agree with you. I actually somewhere in my presentation I said that based on the meta-analysis which I gave the findings from, it was very well tolerated, and even the adverse effects, which are very few, they resolved in 48 hours. Tell me one drug which has can match this kind of safety profile. So I agree with you, right? But again, I'm sorry, I didn't address the medical problems. Yeah, the hepatotoxicity, some of the CNS, seizure, lowering of the seizure threshold, all those things can happen. You're absolutely right. Yeah.
Okay, I'm not seeing any other questions for Dr. Shad. We will move on to agenda item 8, a presentation of the Denver report. Brian Lang with Trans World Health Services.
Good morning, all. Can you hear me? All right. I'm Brian Lang, CEO of Trans World Health Services. I've worked oddly in the space of psychedelic harm reduction since 2007. And I was, for my sins, I was brought on as the medical guy to reform the Psych Services Program at a little event called Burning Man. When I got there, I found that they did not understand patient care, neuroscience, liability, risk management, and the space they put their trippers in. They called the Hotel Moron. So we had a little bit of work to do there to bring that program up to speed. Out of that came a team of 100 professionals to look after people at Burning Man, 80,000 people, not this year, who are more than willing to try substances in ways that are not necessarily indicated or appropriate. And then out of that, I spent 4 years working on a book called The Manual of Psychedelic Support, which goes into how do you provide support for people in psychedelic overdoses. I've personally had the joy of looking after over 1,100 people in acute psychedelic overdose. And I continue to do work in harm education and training around the world. And over the last 6 years, doing a lot of work with companies developing substances that are based on classic psychedelics, working for mental health. Along the way, I was able to work with the Denver initiatives when they went ahead and passed Initiative 301 to decriminalize the use of psilocybin within the city and county of Denver. So what I'll do is I'll just do a brief summary of that, what we found in the evaluation, what we did afterwards, and then open the floor to questions about this. It was back in May of 2019 that Denver voters approved Initiative 301 to decriminalize personal possession, cultivation, and storage of psilocybin mushrooms in the city and county of Denver. As stipulated in Initiative 301, the Denver Psilocybin Mushroom Policy Review Panel, we'll just shorten that to say the panel, was created to assess and review the impact of the initiative in Denver and make recommendations to the Denver City Council. This panel was really concerned with what was going to happen. It had been decriminalized. We were expecting we were expecting a significant uptake in use of psilocybin. We were very concerned with what were the safety aspects of that, both from a criminal justice standpoint as well as a medical services standpoint. Now, the panel was a great panel. It included representatives from the District Attorney's Office, the Denver Police Department, Chief Montoya, Denver Sheriff's Department, the Denver City Attorney's Office, Denver City Council, harm reduction and addiction specialists, and proponents of the initiative. So it was a real diverse panel, certainly with the Attorney's Office and the City Council involved. Everyone's looking at, did the voters do the right thing? Would there be liability associated with this? Or, what was unleashed with this initiative? The output of the panel was known as the comprehensive report, and it was a detailed assessment of Initiative 301. It was published 18 months after voter approval. It included findings on safety and effectiveness, the impact of the initiative, recommendations for harm reduction and data collection, potential partnerships for future support, and stressed the need for informed policies, harm reduction strategies, and community education to maximize benefits and minimize risks associated with psilocybin mushrooms in Denver. Also covered an overview of the safety, use, available resources, arrest data, demographics of offenders, observational data on psilocybin use, and a list of recommendations to the City Council. Apologies for my voice. I have just returned from that very, very, very lovely dusty place called Burning Man, where I served again in a harm reduction capacity. Breathing dust for several days is really no fun. So findings on impact of psilocybin decriminalization. First and foremost, no significant increase in arrests related to the distribution of psilocybin mushrooms. Of the time during which the report was being developed, there were only 5 arrests made solely involving psilocybin mushrooms. That's most of the arrests where psilocybin mushrooms were also present were when you bust a drug dealer and they have a whole array of wares to serve their clients. But very, very few arrests regarding psilocybin. There were no significant cartel elements or organized crime involvement arising from the decriminalization. There were no measurable public health or community safety risks. There were no identifiable changes in hospitalization or emergency medical treatments due to psilocybin use, and I'll qualify that later. There was a decrease in overall arrests related to psilocybin over the pre-initiative 2018 baseline, and psilocybin arrests only represented 0.77% of all drug-related cases. And that's where anybody was arrested with any amount of psilocybin or other substances on them. So very, very low. And there was a limited university research component that was done that identified the use of psilocybin mushrooms was primarily for self-exploration and mental health. Now, the major panel recommendations, first and foremost, remember we have police, we have city attorney's office, so on and so forth. What we found was that there was a surprising lack of understanding, not only just in the public, but in the first responder community regarding what is an acute psychedelic crisis, what to expect. So one of the first recommendations to the City Council was what we called multi-responder training. And that would be training for a police department, sheriff department, paramedics, mental health, and fire department, essentially all your first responders, to maximize public and officer safety, which is a big deal, while minimizing liability through specific instruction regarding appropriate recognition and response to persons undergoing psychedelic crisis. Those educational programs were developed and piloted in 22, and we'll talk about that in a little bit. There was a recommendation for public service programs, educational for public awareness and safety regarding psilocybin use and access to harm reduction services in the city. Curiously, when Oregon legalized psilocybin, its expense precluded a vast uptake of people taking advantage of the therapy, but the black market increased tenfold. because the state had said psilocybin is safe, go for it. That was the message the public got. But there was not all that much education provided to the public, so people launched off and took their psilocybin through the black market channels. So Denver wanted to make sure that that there were public safety programs put out there so that people who saw that, okay, psilocybin seems to be good for people. It's used medically. Everyone from Johns Hopkins to Imperial College to so many of the research publications have said, yes, indeed, there are potential significant mental health benefits from psilocybin. And psilocybin, if you look at the categorization of its general risk, it is the single lowest risk of all psychedelics. By the way, there is the one study on LD50, which is the lethal dosage for 50% of the population, which is an indication of what is the dose that puts people at risk of dying from psilocybin. There was one Czech study, it was a rat study, not a human study, that from which they estimated that it would take 36 pounds of psilocybin mushrooms to be to kill an average human being. 36 pounds of anything is an awful lot to eat. Let's just put it that way. Now, the data collection and reporting was interesting because there was no centralized database, and there was no centralized there was no way to codify within the emergency room and hospitalization systems what was specifically related to psilocybin. Drug overdoses are generally categorized together, and there was no way to differentiate psilocybin, or for that matter, any of the psychedelics, versus opioids versus amphetamines. So one of the recommendations to City Council was the creation of a data collection and reporting system for law enforcement, paramedics, hospitalization, emergency rooms for any interactions involving psilocybin for ongoing public safety monitoring. Other panel recommendations. Under Colorado law, this state law did not differentiate gifting and sharing of controlled substances from felony distribution. So there was a recommendation, given the popularity of mushrooms post decriminalization, that the sharing and gifting for non-financial exchange would be classified as a lowest law enforcement priority. There was a recommendation on inclusivity, where people were to expand the voting panel members to promote inclusivity to better reflect Denver's diversity. And significant to the recommendation was therapy. There was a significant recommendation on how to determine how psilocybin therapy could be applied to address mental health issues in Denver. As you know, various companies are going through the FDA process to bring psilocybin-assisted psychotherapy into the fore, to legalize, reschedule psilocybin from Schedule 1 to a different scheduling so that it may be used for mental health. And the recommendation was to explore how Denver might become a hub for such activities. The conclusions of the report, there was a huge opportunity for Denver to really be at the forefront of psilocybin use to address some of the city's most pressing social, behavior, and mental health issues. The study concluded that psilocybin use was safe. Most people use psilocybin in safe and responsible ways, and the extremely low number of arrests rendered the concerns of Initiative 301's opposition unwarranted. So, from all in all, there really wasn't any big difference in the population, in the safety and criminal justice implications of the decriminalization of psilocybin. There was not while there was probably a significant spike in the use of mushrooms with all the publicity around it, it was largely done in a safe setting and generally for personal and therapeutic purposes. Review of the literature over the last 10 years shows an awful lot, actually, since 2006, and Johns Hopkins legendary study on this shows significant university-originated studies showing benefit of these things. I can certainly say categorically there are significant reasons that more public education is necessary, particularly with people with a family history of any mental illness such as schizophrenia or bipolar disorder. As was stated earlier, if you have people who take psilocybin or any of the 5-HT2A receptor touching compounds, you can send people into significant long-term psychosis. So that's a matter of education. Your doctor would not give you a contraindicated medication when you go to him or her for a prescription. Similarly, you would not want to take a substance where if you knew that it would hurt you, you wouldn't be taking it. And just to put things in perspective, the literature in terms of toxicity over the last 125 years, there are 2 actual warranted studies, verified studies that show that people have died from psilocybin containing mushrooms. That's 2 people over 125 years. It's extremely rare, to the point of we don't understand why those 2 people died. However, we do know that the behavioral aspects are what concerns us about the use of anything that can affect your mind to this level. So, just as an anecdote, I've had to look after people who have been not able to regain their cognitive function or an executive function for weeks or sometimes months after significant misuse of psychedelics. So these are not without risks. However, in terms of risk reward, what we've seen from the academic medical centers doing the studies, what we've seen from the early clinical trials really suggests that we have a huge opportunity here to explore these compounds for our clear public mental health crisis. Now, a little bit of aftermath from the report. Transworld Health Services, my company, was contracted to develop and pilot trainings for Denver Police Department, Sheriff's Department, Mental Health Services, and Fire Department, all the emergency first responders who need to be prepared to respond to drug-related public emergencies. And our trainings cover not just psilocybin, but classic psychedelics and related substances such as ketamine and MDMA. No, those are not classical psychedelic substances. Ketamine is a dissociative analgesic, and MDMA is an entactogen. They're not considered classic psychedelics. We differentiated the recommendation and response strategies between these compounds and more problematic substances such as opioids and amphetamines. The trainee survey responses were overwhelmingly positive, and first responders from law enforcement and the medical services and mental health communities noted that their current trainings did not sufficiently cover what they needed to provide proper first response, and particularly with respect to differentiating between, say, an opioid overdose, a ketamine overdose, or a psilocybin overdose, as when one treats these things very differently. So that the benefit from all of the public self-training, the pilot trainings was substantial. And of course, at that point, law enforcement budgets were cut across the country as you had the defund the police initiatives. You had all sorts of, and first budgets that got cut were the training budgets, unfortunately. So there's a huge need out there for our law enforcement professionals and our mental health response professionals to understand the various differences. You're not going to find very many people tripping out on psychedelics on the street compared relatively to opioids or amphetamines. However, the recognition and response is going to be different for these versus the other substances that are really the scourge of our cities these days. So public safety training was a big hit in Denver. It's something that we wish we would see more of across the country as we deal with the drug crisis. So that's a little bit about the Denver Public Report. I had the privilege to be one of the authors of that report, and really enjoyed the work with Denver, given that the focus on this was, did we do the right thing by our public with respect to safety and medical concerns? And the overwhelming response that the panel found was that yes, indeed, we did not see safety issues arise through this decriminalization process. So with that, any questions? John?
Jonathan?
Yeah, thank you, John Dalton here for the record. Thank you, Brian, for that brief. When you discussed examples of risk in people who have had adverse effects, would you say that dosage, set, and setting were followed and that still happened, or was the environment not, say, conducive for that those kind of therapeutic parameters that are beneficial?
Well, when you get into a wild festival setting such as EDC in Las Vegas, or this little festival in the desert not far from Reno, you have a significant disadvantage with respect to where you are, at what the environment itself. The set and setting is overstimulating. People haven't necessarily hydrated, they haven't necessarily slept, and there's all sorts of drama that can arise from that. So as a result, you're more likely in an overstimulated setting to have a overstimulated public setting to have mental decompensation as a result of ingestion of the substances. There's so much opportunity, and everybody's saying, okay, look at all this research. Oh, look, all these articles are showing that MDMA is, and by the way, for my belief based on the data, and yes, I've been part of those clinical studies on MDMA since the early days. Yes, the clinical study design was absolutely unacceptable. However, as one looks at the results of the compound itself and the benefits, well, I believe the compound will ultimately be proven to be effective and approved by the FDA in some form. There are 2 other companies that are working on this right now that may overtake MAPS. But really, if you look at it, when you're looking at mental health issues, when you're looking at treatment for mental health issues, you're not dealing with a wild festival. You're dealing with controlled environments. When you're looking at people who are taking the decriminalized avenues, when they are doing their work at home, when they're trying to find some truth for themselves based on all that they've read from Michael Pollan and everybody else, they're not in giant festival settings. They're in settings that are much more safe and appropriate and more conducive. And certainly at festivals, this is going to be a problem everywhere. But you look at the inner cities, and I work with a large patient population in Los Angeles, and you look at that, and we're just not seeing psychedelics, and psilocybin in particular, as any significant problem whatsoever in the streets.
Thank you.
Diane?
Hi, Brian. Pleasure to chat with you here again. So I've had the privilege of sitting on a panel with Denver Deputy Chief Montoya, and I think the real interesting question for me is what we started out almost was kind of like a random clinical trial, right? Denver County. Have you seen that extrapolate across the state relative to Measure 122? And specifically, have you seen the Reason Foundation report that recently came out that really looked at more counties, not just Denver, and the percentages? It is really very similar to what we saw in Denver. Are you continuing that work and that research?
Everything that we're seeing and let's just look at psilocybin. We'll not get into our problem child of MDMA, and we of course will not discuss LSD under any circumstances because that's Timothy O'Leary's legacy. But no, we're seeing that this is a very, very safe compound. It is, if you look at the work done by Professor Nutt at Imperial College, which is absolute sentinel and worth, everyone should know that. You see that the problems arising for psilocybin use as they expanded from Denver, as they expanded throughout the state of Colorado, as we're seeing in Oregon, are extremely, extremely limited. They are a very, very small fraction of MDMA. They are a minuscule amount compared to alcohol, compared to opioids, et cetera, et cetera. So this seemed, what we saw in the research in Denver seems to be generalizing across any areas where we're seeing decriminalization or legalization efforts.
And what I just want to make just a final statement is, in the Reason Foundation report, they looked at the 10 largest counties in all of Colorado, and 5 police agencies reported back with no issues at all. 4 had no opinion, and 1 did not respond. And
Yep.
so I think this is really critically important. But one of the things that they also showed was post data was 2021. Total of all arrests in comparison to other drug arrests and alcohol was 2.41%, 2022, 1.96%, and in 2023 across the state down to 1.4. So can you extrapolate an opinion that sensible regulation and public education works to reduce public safety and public health outcomes?
Oh, absolutely. Education is foundational to all of this. And when you look at the numbers, you can look at schizophrenia, for example, in approximately 1% of the US population. So that's a very low number to start. And then bipolar also significantly low numbers. So you're dealing with very, very low risk pools to begin with, known risk pools. And you're dealing, and I have dealt with plenty of people who have suffered from bipolar or schizophrenia, and at low dose have not had any problems with psilocybin in and of itself. So as we extrapolate this, the better the education we have, the better off we're going to be in terms of steering the risk pools away from the use of such substances. Really looking at people, studying what has been done legally or illegally to their benefit. And certainly we've seen that across the board for psilocybin. We've seen that across the board for MDMA in private use, legal or otherwise.
Hey, Dr. Tabak.
Thank you. Tabak here, TABAAC. Please excuse me for lack of video presence. Brian, it's really incredible having someone's expertise to participate in today's call. So I'm very grateful for your input. There's an opportunity to see some best practices that were implemented in Denver. At the beginning of the presentation, you emphasized that Denver, the bill that ended up passing was for decriminalization of possession and growth. Now that the state of Nevada is working on drafting their own legislation, do you think that there's an opportunity for a medical model or even more access for patients?
Well, that's where we get into politics.
Or advice, or what sort of counsel or advice would you give to the legislature as they draft their bill in this state, knowing what you know?
Speaking from a clinical perspective, I have to err on the side of caution. We saw what happened with Oregon Prop 110. Didn't go so well. I see that certainly the data speak for itself as far as Colorado is concerned. Psilocybin was decriminalized successfully, and there really has not been any efforts, any issues really that have arisen. And over that time, we've seen people with significant mental health benefits accrue through the decriminalized use of psilocybin. So on one hand, I would love to say, oh, I wish we could just decriminalize it for psychotherapeutic use. However, we're seeing overwhelming benefits accrue to use without the benefit of psychotherapy, individualized use that we're reading about all the time. So what is the greater good? Do we have all the data we need? Absolutely not. Do we have the FDA clinical trials completed through phase 3? Absolutely not. Anecdotally, we know that over 30 million Americans have used psilocybin mushrooms, and we've had virtually no issues. Yes, there are behavioral issues if you take it in the wrong place, in the wrong setting. Yes, that's an educational issue, and behavioral issues are always going to be significant, particularly with excessively high doses of any of these substances. But we're seeing a mental health crisis expand, and we're seeing solutions. And the more we can get solutions into the hands of the people who need them, the better off we're going to be. And that's why, even with some hesitation, I fall very, very much in favor of the decriminalization of these substances, with educational components absolutely required, because there just aren't enough psychotherapists out there who are trained and qualified and able to do what we need. And we have so much anecdotal evidence and published evidence of people who have achieved benefit through the use of these substances by following the dozens and dozens of books out there for how they can achieve benefit. And that's not just through microdosing, although that simply has taken the world by storm. There's also people who've gone with 1, 2, 3 grams of mushrooms and have had huge personal transformations that have changed their depressive nature, that have changed their suicidal nature into something positive. However, it has to be, if any decriminalization is to be done, it must be done with appropriate public education.
Awesome. Okay, that's really helpful. And my one follow-up question would be, on the back end of the prior talk discussing about REMS programs, can you speak to what sort of training would be recommended, or resources that you would anticipate professionals who would potentially be participating in psychedelic assisted therapy? What does that training model look like? How does that education roll out so that providers feel equipped?
One of the things so any EMT and above is going to understand basics of human physiology, and any educational process is going to have the same thing that we taught to all of to our pilot groups in Denver: recognition of the problems. What is going to be a problem with the substance, and what is the appropriate response? Since the 1970s, there's been a very strange movement to not involve medical response when there is a psychedelic crisis. Unfortunately, the people who are advocating for this are not medically trained. They do not even have first responder. It became a philosophical issue. It dated back to the 60s when Thorazine was used routinely, and that hasn't been used as best practice for dealing with psychedelic overdose for decades. However, the aversion towards involving medical by people who do not understand what a transient ischemic attack is, for example, which, by the way, is not unknown with psilocybin. If you have the basic understanding of human physiology, when to push the big red button, I would be very happy to have psychedelic assisted psychotherapists engage in use of this. Certainly, you want to know what happens in the brain, you want to know what happens in the body, and you want to know the risk factors. You want to have proper screening before you would ever accept a patient under the circumstances. And that's why the clinical studies have such huge disqualifications for their study populations, because there are, as I mentioned, schizophrenia, bipolar, schizoaffective disorder, so on and so forth. These are situations where I could not imagine taking a patient into psychedelic assisted psychotherapy. However, this is really basic training. It's not how to do psychotherapy. It's what can you expect as the brain changes, as certainly with MDMA, when your amygdalic response drops and you suddenly don't have that immediate stressor that comes up with a PTSD patient. How does the body work with these substances? Once you understand that, and you have the experience, practical experience in what happens when things go wrong, then you're going to be much better qualified. I'm often asked, oh, I want to be a psychedelic assisted psychotherapist. What should I do? My response is, how about being a psychotherapist for 10 years or so and understanding the magnitude of what can come up when someone suddenly hits an emotional trigger? Because those emotional triggers will happen so much faster with any psychedelic assisted psychotherapy, and all manner of base brain issues may present, and you better be prepared to handle that. You can't just swan in and say, oh, well, I took a 6-week course and now I'm a qualified psychedelic assisted psychotherapist. When things go wrong, they go really wrong really fast. And when you're dealing with people with extremely deep trauma that we see throughout our population, this is likely to come up. So you as a psychotherapist have to know how to handle it. And that's not something that was taught in most of the courses that were set forth for psychedelic assisted psychotherapy. So I will err on the medical side on any of this stuff. I really, really want to make sure people understand what happens physiologically as well as psychologically.
Thank you. Yamaz, I will ask you to reserve any of your comments until the end in the public comment section. I want to move on to the next presentation. And Kate, if you don't mind, I would like to move to item 10 and have, if we have Lieutenant Steele on, to allow him to do his presentation. Just in the interest of time, I want to make sure that we accommodate him. So
Absolutely.
if
Absolutely.
Lieutenant Steele is ready, please go ahead.
All right, thank you all.
Thank you. Can everyone hear me? I'm assuming you can. So this is a formal presentation. Chairwoman Williams and distinguished members of the Nevada Psychedelic Medicines Working Group and honored guests, thank you for this opportunity to appear before you today to speak about the exciting potential of psychedelic therapies for American veterans. I want to recognize John Dalton, who is on this call, for his assistance in regarding our participation today. My name is Martin R. Steele, and I'm a retired Lieutenant General in the United States Marine Corps. I had the privilege of wearing the uniform of a Marine for nearly 35 years, rising from enlisted private in 1965 to 3-star general and retiring in 1999 as the Deputy Chief of Staff for Plans, Policies, and Operations, which in civilian parlance is equivalent to the Chief Operating Officer of the United States Marine Corps. Following my active duty service, I served as the Chief Executive Officer of the Intrepid Sea Air Space Museum in New York City, including during the 9/11 terrorist attacks. Afterwards, I served as the Associate Vice President for Veterans Research and the Executive Director of Military Partnerships at the University of South Florida in Tampa, Florida, working with scientists exploring the comorbidities between traumatic brain injury, post-traumatic stress, military sexual trauma, both to men and women, prosthetics, and robotics. My work resulted in U.S. Senator leader at the time, McConnell, Republican from Kentucky, appointing me to the Commission on Care, which was established during the Obama administration to make recommendations about the future of VA healthcare, which was in crisis due to the high suicide rate. Many of the commission's recommendations were brought to light by Congress through various pieces of legislation, such as the Mission Act, the WISE Act, and the PACT Act. I've also testified before Congress separately 3 times on veteran suicide prevention. On a more personal level, my stepfather, who raised me, was a World War II fighter pilot who became a prisoner of war in Stalag Luft 1 in Barth, Germany. He suffered immeasurably with post-traumatic stress for the remainder of his life, leading to significant alcohol use and abuse. He died in a VA hospital on November 11th, Veterans Day in 1995 as a result of the complications related to his alcohol abuse. Thus, my personal and professional experiences have provided me with a deep understanding of the struggles our veterans face, particularly in relationship to mental health and substance use disorders. These are challenging issues to address, and I've listened attentively to every person who reported before me, but I firmly believe that we have a moral responsibility to provide those who selflessly served our nation with the best care possible to heal from the invisible wounds of war and live meaningful and fulfilling lives, particularly after this global war on terror that lasted in excess of 20 years. Unfortunately, we have fallen short on this front for many years, with far too many patients not benefiting from currently available medications or therapies, which everyone has been saying up to this point during this meeting. This has brought me to my work over the last couple of years, leading Reason for Hope, a 501c3, and the Veteran Mental Health Leadership Coalition, a 501c19. These organizations help develop policy and advocate for increased access to psychedelic and other emerging therapies for various mental and behavioral health conditions. Our coalition members include several researchers and mental health providers within the VA healthcare system, leaders of various veteran service organizations, and many veterans who have been forced to seek out psychedelic therapies abroad or through underground providers in the United States, despite the risk of criminal prosecution, which has also been highlighted today. These psychedelic therapies generally encompass use of substances like MDMA, psilocybin, DMT, ibogaine, and 5-MeO-DMT in controlled settings, utilizing protocols involving preparation, carefully monitored drug administration, and integration sessions, a process that we now know as psychedelic assisted therapy. While additional research will always be needed, a growing body of evidence suggests that these psychedelic therapies can provide rapid, robust, and durable healing for a variety of mental health conditions. Rather than merely masking symptoms, which I would include SSRIs in that, which have been discussed, these therapies can better address the root cause of trauma and lead to lasting behavioral changes, helping patients break free of rigid patterns. I've been fortunate to work alongside many veterans who attribute psychedelic therapy to not only saving their lives, but also to instilling a renewed sense of purpose, meaning, and connection to themselves, their families, and their communities. Of course, these therapies are not a magic bullet, as you've heard today. As with any treatment, they are not without risk. We know there are some patients who will have a very difficult time and potentially feel worse before improving, who may not improve at all, or who experience concerning psychological side effects ranging from suicide ideation to rare extended difficulties such as disassociation and derealization. Moreover, patients are in a vulnerable state that may leave them at greater risk of exploitation by abusive providers. Nonetheless, considering the limited drug exposure and use in medically supervised contexts, the risk profile of psychedelic therapies for most patients may be comparable or better to that of daily SSRI use, with fewer side effects and lower potential for dependence and withdrawal effects. In terms of clinical trials to support potential FDA approval, MDMA and psilocybin are further along in the pipeline, and the FDA has awarded breakthrough therapy designations to MDMA-assisted therapy for PTSD, 3 different psilocybin therapies for depression, 1 for treatment-resistant depression, and 2 for major depressive disorders, and an LSD-based drug for general anxiety disorder. This means these treatments have demonstrated sufficient safety and that they may be substantially more effective than the existing medications for these particular conditions. Unfortunately, as we've discussed today, on August 9th, the FDA declined to approve Lykos Therapeutics' new drug application for MDMA-assisted therapy to treat PTSD, finding the data packet insufficient and instead requesting an additional phase 3 trial. This will likely delay approval for this potentially life-saving treatment for veterans by several years. We now expect psilocybin to be the first of these behavioral therapies, breakthrough therapies, which will be approved specifically for treatment-resistant depression, likely by 2027. In the meantime, all of these psychedelics remain Schedule I controlled substances. This not only slows down research, but it also increases our cost and has historically led to very limited public and suppressed private funding. Additionally, Schedule I blocks compassionate use under the Right to Try Act for patients with terminal or life-threatening condition, even if a drug is otherwise eligible for access under the law. Considering the devastating mental health and suicide crisis plaguing our veteran community, it is unconscionable that so many continue to be forced to go out of the country or risk criminal prosecution in the United States to access these potentially life-saving mental health treatments. Particularly as to the breakthrough therapies, there is clearly evidence for doctors and patients to make informed treatment decisions about compassionate use in advance of FDA approval. In advance of FDA approval of these breakthrough therapies, state governments are playing a critical role in addressing several of the challenges noted by funding research pilot programs for veterans to swiftly access this potentially life-saving treatment at no charge, while providing the necessary education and hands-on clinical training opportunities for healthcare providers treating the veteran community. Even post FDA approval, implementation, research initiatives can collect critical data to help inform standards of care, insurance coverage, and potentially more affordable and scalable treatment delivery models in real-world settings. Convening this working group in Nevada is a critically important step to prepare the state's medical system for these new to us healing modalities. I firmly believe that the state of Nevada can position itself as a leader in the clinical rollout of psychedelic assisted therapy by investing in quality research and treatment initiatives that inform medical providers on best practices, empower insurance payers with quality data, and create training opportunities for prescribers and therapists. The need and the urgency could not be greater than it is today. I want to thank you, and my team and I are happy to answer questions that you might have there on this call. One is Dr. Lynette Averill, a psychologist and clinical researcher at the DeBakey VA Medical Center in Houston and associated with the Baylor College of Medicine. And the second is Mr. Jesse McLaughlin, a former legislator in the state of Connecticut, who is our organization's state advocate, who has gone from state to state in regards to trying to do and implementing several programs, which has generated legislative money throughout the United States. And we're hopeful that we can help you all in the state of Nevada to do the same thing. So I'll open it up for any questions now. And I thank you for allowing me to go before someone else that was in the schedule. But it's an honor to be with you today. And thank you for all the work that you're doing. Continue to do it. Thank you.
Dr. Shad has a question.
Yeah, thank you very much. Very, very nice presentation, very impressive. I just wanted to talk to you about one of the issues. I don't know whether you were able to hear my presentation.
I did.
And I forgot to mention that when I was talking about emotional numbness with SSRIs, and we have written a very comprehensive review paper on that, you can easily find that in Google, is that, you know, if you give SSRIs to a PTSD patient, it is going to really, instead of improving, it will increase emotional numbness, which is a huge problem in veterans because their families are already stating the fact that they are not the same person which before the war, and they came back, they look different. They lost this ability to have love and affection for their loved ones, right? And so SSRIs actually is not really, I'm becoming very offended by use of SSRIs in PTSD, because the only thing they do is to help with the secondary depression which can occur after PTSD, but nothing else. No improvement in startle reflex, no improvement in nightmares, no improvement in flashbacks, nothing, right?
Yes.
And on the contrary, we talk about psilocybin, which has nothing to do causing emotional numbness. It helps emotional responsibility tremendously. So I
Yes.
just wanted to support what you said by saying this. Thank you.
Yes, I was reinforced that I agree with everything you said, Doctor. I listened to your fine presentation earlier. My lived experience has been for decades with the Veterans Administration and dealing with the patients there, their comorbidities, their post-traumatic stress, and their treatment protocols, which involve SSRIs. And I agree with what you said regarding their outcomes, if you will, the success rate, which you didn't mention by percentage, which I have all the numbers. Reality is very few have success. It takes months, and those who do are very rare. But the lion's share of the people we work with leave that protocol and come to us looking at viable alternatives because they have a desire to live a productive life, and they're not because of the reasons that you stated. The other thing that I'll say, again, on the global war on terror, there are 2.3 million veterans. And then when you add on first responders, which we've talked about today, when you add on the exacerbation by COVID, medical health providers, one of which is my daughter, this has grown exponentially as a crisis of proportions that we've never seen in our country today. And the percentage of people, which was very low when we started all of our efforts, and the VA was saying, we don't anticipate that many. We kept using the metaphor about an iceberg, that they only had exposure to the very tip of the ice, and that of the 2.3 million, our estimates, and this is me personally again, because of all the people I've been dealing with and communicating with, some who are fearful even to try to get treatment in the VA because of the word of mouth regarding the VA's inability to be able to help. I mean, it could be as high as 60%. And the longer we wait, I just think about my stepfather, as I mentioned, my era. I had 2 tours of Vietnam and then the first Gulf War, and now this 20-year global war on terror. It took 10, 15 years. I've got a friend of mine that I served with in Vietnam that just admitted to me 6 months ago about his PTS. That's 50 years ago. But he's been dealing with it all his life, and he won't go to the VA to get treatment. He won't do it. So we're in a crisis, and the VA has done some things recently, very recently, because we've been coercing them and helping them to understand, rather than be a fast follower in this space, that they need to be the model to emulate because of the cohort that they are charged with treating for their selfless service to our country. And it's slow, but we've released through the Breakthrough Therapies Act, which is not about decrim or not about legalization. It's about rescheduling, as been said earlier, including Dr. Bryan earlier in his comments. This is going from Schedule 1 to Schedule 2 because Schedule 1 is so difficult, and people they don't want to get into it. It's so hard. Nor does the VA want to get into it because it's so difficult for Schedule 1 research. But if we can get it to Schedule 2, open it up for expanded access, and do the research and oversight, the training, as the doctor was talking about also, which is critical. We've been involved with the VA about how they would train their cohort of providers. They were 76,000 providers short in 2015 in the mental health arena alone. And so we've got to fix that. We've got to get them engaged in all of this to be able to be actively involved in supporting viable alternatives. It's a challenge when you think that their protocol now, they treat a patient once every 15 minutes and then normally provide an SSRI. They come back 30, 60, 90 days later, they get a different SSRI if that one didn't work. And then in the meantime, if they're still alive and they haven't taken their own life or gone off the edge in some other way, they find that it's just not working. And for them to go through this protocol, it was just described and has been by a number of people here, and the time that it takes and the oversight and the follow-on therapy, That's not 15 minutes every 30, 60, or 90 days. And we believe that in the long run, that will be much less costly. It'll be much more effective, and we'll have outcomes that will lead to productive members of our society who serve so selflessly, just as our first responders have. You know, we talked about, and there was police questions early on. I work with police chiefs and police officers and firefighters at the highest levels on a regular basis. They've got the same challenges. I mean, if someone comes forward with issues of crises regarding their mental health in the police force and the firefighting force, they're not allowed to do that while they're on active duty. They're not, and they get sent out if they've got these kinds of issues. So they hold it all inside, and we've got to wait till they retire or whatever, where we can help them and work with them to be able to ensure that they can get these proper treatment protocols to save their life too. So I know that's a long answer to a short question or comment, but I want to thank you, and I agree with everything that you said, Doctor, in your opening comments.
Thank you.
Thank you. So I do want to note for the record that Mark McBride with the Department of Veterans Services has joined our call. So he's a member of the committee. Dr. Averill, did you have a comment before we go to the next question?
Nothing urgent. I was just going to reiterate that I also agree with Dr. Shad's comments, and I think the difference in terms of healing that people, especially individuals with chronic or complex conditions, can find with SSRIs relative to what they can find with a psychedelic, specifically psilocybin, it's just an entirely different conversation, an entirely different experience. I've had the opportunity to do a fair bit of research, and we've published some, including with Special Operations Forces veterans who say their experiences with psychedelic medicine are among the most meaningful things that they have had in their life. I can tell you no one ever says that about starting Prozac. And yeah, I think, you know, to the point of emotional numbing and all of the other various really unfortunate and distressing side effects that often leave folks feeling worse than they did in the beginning. You know, as I have sort of commented in the chat throughout, psilocybin really is a very safe intervention. There are very limited side effects, and it actually does do a lot neurobiologically and behaviorally that is specifically relevant and useful to depression, PTSD, suicidality, anxiety, all of these things.
Thank you. Dr. Hines.
First of all, General Steele, thank you so much for your presentation, and thank you for your service. And my question actually is for Dr. Averill, if that's okay. So I'm very fortunate to be doing some research currently with the VA in Las Vegas with Dr. Lucy Land, who's looking at psychedelic therapy. And I think there's no debate on this call, at least everyone understands, this is saving lives. We're excited about that. But some of the early data is actually potentially showing that it's saving money. So we're getting more compliance, and we're also maybe potentially decreasing other pharmacological agents that these people are on. Do you have any data like that? Are you looking into those things? Can you comment on that in general? And thank you for what you're doing.
So yeah, it's a great question, and I think a critical question and critical point to discuss. We are evaluating those outcomes in our studies. I'll say here in Houston, where I'm based, our data collection is pretty early on, so I can't tell you those outcomes yet. I can say, though, that there are groups that have looked at that. There's a group at Berkeley who is like an economics group who is really carefully evaluating, you know, are there cost savings in these interventions? If so, what is that? Might there be cost savings if we, you know, move forward with the medical model, but explore other ways of treating, such as group-based interventions and these sorts of things? Of course, the way these interventions are being put forward right now, as I think has been discussed, you know, they are very time and resource intensive up front. However, if we consider with SSRIs, talk therapy, these sorts of things, often that is lifelong for many people, or at least a very, very long time that you're going to be taking a daily medication. You're going to be seeing a therapist, or, you know, you go do 3 months with one therapist, take a little hiatus, go see another therapist. The thing that seems to be very exciting about these, and again, of course, this is not, a one size fits all golden bullet, any of those things, is that there seems to be much more rapid, robust, and durable effects in terms of therapeutic benefits. So if we think about, yes, there is a large upfront cost, but people are actually then not having as many emergency room visits, not having as much trouble with homelessness, with substance misuse, with domestic violence, with interpersonal violence, with any of these sorts of things. Those are the cost savings of that, right? Can't be overstated. Certainly, the savings of actually quite literally saving lives. I often think of PTSD, depression, these sorts of things as life-threatening illnesses. We know if people are not getting effective treatment for these, that in all too many cases, those individuals end up dead, whether that is through suicide or other means. So I think the cost savings is something that there's limited data at this point. Elliot Marseille is the person at Berkeley who's done some of this research, and I think they have published maybe 1 or 2 papers so far. I can try to find those quickly and add them to the chat or send them along later. But the thought is, yes, if we have interventions that actually offer healing for individuals, not only will they maybe not need to be continuing to take an SSRI or see a therapist regularly. I will make the note, if they do, certainly some people that I have worked with do go on to take an SSRI again, but actually find that it's helpful now, that the symptoms are different enough and changed enough that an SSRI can kind of just give a bit of balance there. But yes, all of the other pieces, if we actually offer healing for folks and they are able to build a life that they actually want to be living, I think that's another thing I would state just very briefly, is how many people comment that psychedelics provide an improved sense of meaning and purpose, an improved sense of connection to themselves, to others, to nature, the divine, whatever those pieces are. We know that sense of disconnection or not belonging is incredibly negatively impactful in terms of mental health, wellness, suicidality. So being able to get people to a point where they actually want to be living and want to be contributing is huge in terms of obviously the costs to the individual and families, but also economic costs. Absolutely.
Thank you so much.
Jonathan.
Thank you, General, for your powerful and compelling presentation. That is exactly what we need to understand how to help veterans and first responders as well in the state of Nevada. I'll try to be quick on this. In fact, Dr. Averill's comment about larger upfront costs segues perfectly into my question for Jesse. Jesse, what do you believe states need to invest to get these programs off the ground? And how do states find the money to do this work? And I understand that question probably could last a long time. And so a condensed version of this would be great. And we can follow up with something to include in the report later so that we can get granular on it. Thank you. Go ahead, Jesse.
Sure. Thanks for the question, John. It's a really important question since, as we know, it's while the federal government via FDA is in charge of regulating drugs and drug development, it falls to the states to regulate the practice of medicine. And this modality is a unique combination of a pharmaceutical drug with therapy. So it'll follow the states, and we're looking at a pretty significant workforce development need, as General Steele pointed out during his comments. And so what states can be doing right now, and what we've been working on at the Coalition and Reason for Hope, is aligning general fund appropriations, allocating general fund appropriations for unique pilot programs within state agencies to be issued as either grants or direct line items to research institutions for primarily open label studies, open label investigator initiated trials. These have a number of benefits. The first being the data produced from the trials is going to benefit the discipline as a whole benefit the field, understanding safety profiles, being able to experiment with alternative settings and trial designs, patient populations that are normally precluded from clinical trials due to having contraindications or multiple indications that make it difficult for them to make it through screening. So I'll give you a perfect example. We passed a bill in 2022 to create a pilot program within the state of Connecticut's Department of Mental Health and Addiction Services to allow them to fund clinical research of psychedelic therapies. They contracted with Yale Department of Psychiatry. In the next year, we were able to allocate funding. So we secured funding of $1 million in the general fund. That largely came about because of the funding states are utilizing from and received from the federal government due to the American Rescue Plan. So COVID relief money created some pretty significant budgetary windfalls at the state level. So we were able to secure about $1 million for that study, and it's going to be used to treat veterans, first responders, and frontline healthcare workers with psilocybin-assisted therapy, with a unique value proposition of broad inclusion criteria. And so a specific, DSM indication isn't necessarily required to qualify. You just need a diagnosis, not a particular specific diagnosis. And it's really one of the first studies of its kind. So we're going to be able to get some really good data on the tolerability of psilocybin on folks with complicated patient profiles. That's going to be very helpful for insurance and insurance reimbursement purposes. And the clinical trial itself serves as a administration session training opportunity for therapists who may have already received online training from Naropa or CIIS, but they've yet to sit in a clinical setting with a patient and conduct an administration session.
I'm sorry, I have a quick follow-up to your comment about, so the money was set aside to allow for treatment. So who is providing the treatment for those patients?
The Yale Department of Psychiatry wrote an IND. They wrote a protocol, went through the DEA process for their Schedule I license, went through the Yale IRB, and they will be administering the study. The state of Texas passed a bill in 2021 to allocate, I believe, 1.4 million. Correct me if I'm wrong, Dr. Averill.
2.1.
2.1 for a clinical trial of psilocybin. The Baylor College of Medicine was written into the bill along with the appropriation to carry out that study. Dr. Averill is running that study. That's going to create a training opportunity for therapists. We're working on a project in Illinois. We were able to secure around $6 million in the Illinois state budget to create a novel pilot program within the Department of Healthcare and Family Services to treat veterans through a clinical trial, working with a community-based care provider to roll that out with the primary goal of both creating access for vets now through this open label trial and training as many therapists as we possibly can to bolster that workforce, and not only train therapists to be qualified to conduct administration sessions and of course the preparation and integration, but also help them get to supervisory levels of qualification where they can offer training to new therapists who are looking for that without having to travel to a different state in order to receive their training from a supervisor. So there are a number of bottlenecks that we see to adoption, workforce development being a major hurdle that the states can begin to chip away at through appropriations. And that can come through the general fund. And we're also looking at opioid settlement funding as an additional stream. Although that is a bit more complicated given that it is it's a new funding stream And each state has its own very unique, bespoke opioid settlement funding structure as far as the way that their advisory boards and governing bodies make decisions on how those funds are spent.
Thank you. Diane, go ahead.
Yeah. Jesse, thank you for, I was going to ask you about the opioid settlement money. So you just answered that. So really this is for you, General Steele, and thank you both for being here. I'm a retired lieutenant and working in the policy space, both domestically and internationally around the issue of officer health and wellness and model policies. And I know this is anecdotal in some aspects because there's a lack of data, I believe, seeing who's currently accessing this. But in your contacts with both the fire service and police leaders across the country, are you seeing the recognition for calls for model policies that the moment things are rescheduled, or how to put policy and law together so firefighters, nurses, medical practitioners, law enforcement, in fact, have safe access to these modalities?
Yes, it's a simple answer. I mean, they're at the further we're along and the more education that's provided and the need is so amplified, the more the answer to that question is yes. They're just trying to get over the hurdle of what do they do if that person that you're talking about is still serving. It's just like in active
Absolutely.
duty. It's a problem with an active duty military person on treating them, and it's a condition we're continuing to work on. This is an iterative process as far as we're concerned.
Right.
Breakthrough Therapies Act, rescheduling these medicines from Schedule 1 to Schedule 2, and working with the Controlled Substances Act is the first major step that's going to enable us at the federal level. It's the only bipartisan and bicameral bill in the Congress of the United States. So we've got strange bedfellows in the Senate. Rand Paul, Republican from Kentucky,
Right.
and Cory Booker, a Democrat from New Jersey, are the co-sponsors. The same way in the House, it's Senate Bill 689 and House Resolution 1393. But they are bonded because of education, which is what's been talked about here today. I go back to everybody that preceded me, and I got to listen to everybody. It's about education. And they may be fearful at the outset. I'm talking about our policymakers and politicians. But once you get through this, and once you have exposed them to these young men and women
Right.
who are experiencing these traumas and the relief they got through psychedelic therapy by having to go outside the country, it's a metamorphosis. It's a change completely that they know they've got to do something. And the first step is this rescheduling, because it's not about money. It's not about
Right.
decrim, not about, I mean, I get everything, what everybody's doing here. But what we said first, we've got to reschedule so we can get the research done and get
Right.
the oversight done and get that there's no criticisms like what happened with the FDA and MDMA and Lycos. But we can't afford to go through that again because we'll kick this can down the road forever. We've got to get this right and do the right things and be so comprehensive and have all of the data, which we've been talking about this entire day so far, that's going to make this unassailable, is the word I'll use. Will make this unassailable. That there's a need for this alternative protocol for treatment and mental health in a crisis that we've never experienced before, and stop the madness and think about whatever your personal agenda is. So I say that what we've got with this bill, the Breakthrough Therapies Act, and all the partners, I mean, I could read so many senators' names here and House members that we've been able to fortunately educate, get through all the wickets. It'll be ideally passed this year. I don't want to knock on wood here, but hopefully we'll be able to get there with this first major step of the Breakthrough Therapies Act this year. So the answer to your question is yes. So
both Jonathan and I were in DC with Heroic Hearts and a number of other veterans organizations recently. And so I think it's really critically important for this working group to understand that there was not a single meeting that was attended by anyone in that large coalition that day that Juliana Mercer did that opposed exactly what you're talking about. And in fact, it's political will that is causing the logjam. And so, you know, thank you very much for all the work that you guys are doing. And I will continue to support veterans as you guys have been the tip of the spear on this.
Thank you. I mean, Jesse was there, I believe, right, Jesse? I mean, I had a conflict and couldn't go that, but I know what happened during that session. And Heroic Hearts is a member of our organization. Jonathan is part of that, what we're doing. And so we've got 45 organizations now that are all embracing this. And that's powerful when you're walking in and you can say that in your introductory statement to a member of the Senate, not a staffer now, I'm talking about to a member in the Senate or the House. Doesn't matter whether they're a Republican or Democrat. Doesn't matter what their previous position was. Doesn't matter how long they've been up there. You're talking about this crisis because without exception, somebody, a member, they have a family member, they have someone they know that's been adversely affected or perhaps even took their own life. And so they're listening now, and we're at a moment of truth here to be able to do this. And that's why I'm so excited about the state of Nevada, this working group, and what you're doing, and how much we'd be honored to be able to help you navigate this as you take it forward. That makes sense.
Thank you. Before we go to Dr. Shad, we have about 15 minutes left in our time. We still have Kate scheduled to present, and we still have public comment. So, Dr. Shad, if you wouldn't mind submitting your question. You're muted.
Marla, it's okay, because I just wanted to come back to the comparison between the older antidepressants or the other currently available antidepressants, but I think it's okay. I can do it some other time.
Okay, thank you. So Kate, so I'll give you the option. We can schedule you for the next meeting, or you can try to motor through, but recognizing that we probably are going to start losing people at noon.
Yes, I understand. I think it might make sense to push to the next meeting for the sake of time and public comment.
Okay. All right. I appreciate that. Thank you. So I did want to remind everybody that our next meeting is October 11th. Right now it's designed to be the last meeting. So we have a couple of topics that we will carry over for there. You know, I do hope to have a draft of a report available for your review and comment at that time, and then we'll assess whether or not we need to hold another meeting to move things forward from that. So right now, then I would like, unless there are any questions about that piece very quickly. Okay. So item 12, to provide public comment telephonically, dial 775-321-6111. When prompted to provide the conference ID, enter 950-345-302#. If providing public comment during the Teams meeting, unmute your microphone prior to speaking. Persons making comment will be asked to begin by stating their name for the record and to spell their last name. Is there anybody? So we have Frank, do you want to go ahead with public comment?
Yes, thank you very much. I appreciate the opportunity to speak. So my question is regarding the education, not just for the community, but also professionals in the medical and mental health industries. What's been done to align with local organizations and communities that have been working with and researching psychedelics to better assist in this transitory phase into safe access for Nevadans?
So this is public comment, so it's not designed to be a back and forth opportunity, but I can tell you that we have not done anything in the state of Nevada. This is the first effort, essentially, this committee, based on legislation from the 2023 legislative session, for us to look at this issue and see if there are recommendations that we can make back to the state legislature. So right now, nothing formal is in place. Any additional public comment? Jonathan,
yes,
did you have something?
Yeah, Marla, I apologize. I couldn't get to my mic button fast enough when you were on section 11 discussion of future topics. And so I'll just throw these out real quick just so that we can put them on the record for the next time. Real quick, I had 4 different points. So the first one was for future topics, and also where is the data from both Metro and statewide law enforcement groups on these medicines that was requested the last time? And I don't know if we've seen it yet. If we have, I simply don't have access to that. So I need to get access to that. Second, what will the report creation and editing process look like? How will the working group members be involved in both the creation of the mandatory action plan and the report? And can we make edits to the final draft product? Third question asked is if we can include a list of research in the reports for good sources for legislators to have for the record. And then finally, where the research and reports put in both the chat and the presentation, where are the research and reports that were put in both the chat and all presentations from the past meetings and even the links provided today? Is there a common location that we can go to access those? Because those are all really salient data points that we want to be able to get into the record. That's all I got.
So regarding your first point, I will have to go back and look and see what we've done with respect to that. I will create the report as a draft based on the information that was presented here. I will go back through the legislation and ensure that we're responsive to the points that were outlined in the legislation. As you know, we don't have any authority to do a bill draft. All we have is authority to consider issues. And so the outline of the report will be essentially, these are the issues that were considered, and these were, this was information that came forward. The list of research will all be attached. So anybody who has additional research that you want to send, if you can just email it to me. We do have the listserv, and I will post that in the chat now, where we have maintained the information on meetings, working group members, and attachments from meetings. So I'll post that in the chat now. And if you're not on the listserv, make sure you sign up for the listserv, because that is where I communicate to non-members of the committee. So that will be there. If there's right now, I have not posted all of the links that have come through. You know, I probably will do that. I will search through, and I think it probably is important for verification purposes for anybody to say, well, you missed this or you missed that. So I will try and go through and get that done so that people can see what was posted. I think it's somewhat clear that we are not going to gain agreement on some of these issues. We're not going to gain agreement on decriminalization or not decriminalizing. We're not going to gain agreement on how to manage administration of medication, because we've already gotten too many conflicting perspectives on that. My responsibility in managing this committee is to outline those perspectives for policymakers to be able to see what's out there, and they're going to have to make their own decisions based on the information that was presented. Okay, let's go to Nicole.
Hello, good morning. It's still morning. My name is Nicole Bafong. I serve as an executive with Minorities for Medical Marijuana. And I also am a former board member of the Chamber of Cannabis. I'm very thankful that this work group has put together to discuss what would be best for Nevada. My only comment for now is that I hope that this group does some research and looks into the rollout of medical cannabis in the state of Nevada, and we don't make the same mistakes. We don't make the same mistakes in providing the medicine to patients, and understanding who qualifies, who doesn't. There's a lot of different factors to think about, but I'm hoping that we can learn from what cannabis did in Nevada when it first initially rolled out its medical program, and then kind of look at how we want develop a program that fits Nevada's patients, that also benefits Nevada's patients for the state of Nevada. So I really appreciate you all giving some time for comments and allowing me to have the floor. And I just appreciate everything that you're doing here to have this discussion and make sure that this medicine, this very essential medicine, is provided for Nevada patients. So thank you so much.
Thank you. April?
Hello, can everybody hear me? Great.
Yes, we can hear
my
you.
name is, thank you. My name is April Contreras, Contreras for the record. Many thanks to the chair of this meeting and all here for your public service and dedication to the citizens of Nevada. I've lived in Nevada for 21 years and I'm proud to call it my home. And I've seen firsthand what trauma and substance use disorder can do to a family. And so I'm inspired to contribute to the empirical, rigorous body of research on entheogens like psilocybin and other psychedelic medicines as alternative therapies for substance use disorder, major depressive disorder, and PTSD. And there are several studies that have been published in highly vetted research journals like The Lancet and New England Journal of Medicine by research groups at Johns Hopkins, Imperial College London, and New York University, which report on the efficacy of psychedelic-assisted therapy to treat addiction to substances including nicotine and alcohol, to treat major depressive disorder and PTSD. And this release is provided to individuals in these studies that have been reported for up to a year. And the data from these rigorous studies is compelling and accessible to the public. And so I'm speaking here today because I've seen some comments from Nevada law enforcement, including the Las Vegas Metro Police Department, suggesting that there has been an uptick in use of psychedelics at local music festivals, and that this is an issue relevant to the use of psychedelics to treat mental health disorders. So I'm specifically referring to some comments made by Joshua Garber at the working group meeting on June 25th, 2024. I've not seen the data from these reports, so I'm wondering if you can provide and submit this data on the record. I'm formally requesting this data to be provided by local and state law enforcement. I want it to be included on the record and submitted for both the public and this working group to review. Thank you.
Thank you. Diane?
Yeah, just to that point is after our last meeting, I specifically asked for the questions that I just dropped into the chat. And I would like some type of breakdown for our report. And if we can't get the data, then we need to provide within the report some type of mechanism to ensuring that we get compliance with data, because we can't make appropriate decisions about anything without data. So appreciate it. Thank you very much.
Thank you. Is there any other public comment? All right, then next meeting is October 11th and we are adjourned. Thank you, everybody.
Thank you.
Thank you.
Thanks, everyone.